ladies and gentlemen. Good morning, good afternoon, good evening, wherever you're joining us from. Welcome to this important meeting titled Botulinum Toxin versus Surgery and Evidence-Based Topic Debate and Discussion, Thinking Outside the Botox. Organized by the Saudi Ophthalmology Society and the Saudi Group of Pediatric Ophthalmology and Strabismus. Strabismus is a complex ocular condition that affects many individuals. Botox or botulinum toxin has emerged as a promising non-surgical option for addressing misalignment. In Saudi Arabia, the use of Botox for strabismus has been widely adopted since its introduction to the country in 1991 at the King Khalid Eye Specialist Hospital. In this meeting, the esteemed speakers will share their expertise on Botox for strabismus surgery, discussing evidence, guidelines, and best practices. We encourage active engagement through asking questions through the Q&A at the Zoom, and also through answering poll questions. The poll question QR code will be out on the slide, so keep your phones very handy. They will be on the screen here and on your screens at home. This meeting is an interactive meeting, and it's informative and also a platform for collaboration and networking. I want to express my gratitude to our speakers, organizers, and sponsors. Your efforts have made this meeting possible. And we appreciate your commitment to advancing pediatric ophthalmology and strabismus management. Let's embrace the power of shared knowledge, collaborations, and cutting-edge techniques to provide the highest quality of care to our patients. Thank you, and let's begin this enriching meeting together.
We have a great lineup of speakers, and the first session will be dedicated to discussing Botox, special uses in strabismus surgery. And without further ado, the first speaker will be Dr. Shadar Al-Frehi. She's the division head of pediatric ophthalmology at KASCH, and she's an associate professor. And she will be discussing the pathophysiology, preparation, and injection technique of Botox. Dr. Shadar.
Thank you. Before we start, please scan this QR code and answer this question. So we would like to know, how often do you use Botox in your practice? So just to touch base and know how many of you are familiar with the use of Botox. So not at all, or I use it frequently in about 50% of my practice, or I use it more than 50% of my practice, or in selective cases. Okay, I think the majority uses it in selective cases. Okay, great. So what is Botox? What's the mechanism, preparation, and injection techniques of Botox? So Botox is derived from the first few words from botulinum toxin, which is a botulinum toxin A. So Botox gets its name from the first few letters. It's derived from the Clostridium botulinum anaerobic spore-forming gram-positive bacteria, and it's a purified protein complex. It's the deadliest substance known, as 1 gram can kill 1 million humans through food poisoning. It produces potent neurotoxins, 7 serotypes, and we use A and B are the most commonly used. One cannot talk about Botox without mentioning the great work of Alan Scott. He's quite a very impressive and pediatric ophthalmologist from San Francisco who introduced Botox as it's used nowadays in our field. There's a paper that he published before his passing in 2021. And in that paper, he said, I learned about the restricted local effect of injected botulinum toxin type A from a chapter by Daniel Drashman describing the toxin's effect and hind limb development in chicks. So he was thinking outside the Botox, actually, outside the box. He was thinking of using a toxin into good use, to bring a toxin into good use. So I think we should all be proud of his thinking and encourage younger generations to think like him and do research. He never made any profit from introducing Botox, and it actually never crossed his mind that it will be used in the way it is right now. Okay, so it's quite an inspiring story, and he's a pediatric ophthalmologist, so we should all be proud of that. So what's the history of Botox? So Botox was described in the early 1895 as an outbreak of food poisoning occurred in Germany. So a group of people ate pig sausages, and they had food poisoning. 13 of them, half of them died. And that was the first description of Botox or botulinum toxin in history. And then in World War II, they tried to weaponize Botox. They tried to use it in their labs as a weapon, okay? And that's how Alan Scott got the Botox from. From after the war has ended, he got some Botox to use it for his research in his lab. In the 1970s, he started using it on trying it on mice and monkeys before actually giving it to his first human patient. He applied for the FDA to start using it and try to inject it in humans. And in 1977 was the first time it was ever injected in human. He described it in this paper, and he said he had to admit the patient under the protocol for 3 days in the ICU to get it approved. Although he thought it was safe from his previous research in monkey, but he had to follow the protocol. The name of Botox was not Botox. Initially, he called it Oculinum, and this is one of his vials from his research. So Oculinum is an eye aligner. And he tried to get it manufactured by drug companies, and he struggled. He faced a lot of struggle to convince drug companies to manufacture and sell his product. It was not until 1989 that it was FDA approved, and then it was widely adopted. It was first FDA approved for strabismus and blepharospasm. So this was the first use of Botox and FDA approval, blepharospasm and strabismus. Afterwards, a couple from Canada, an ophthalmologist and dermatologist, noted that when they injected it for blepharospasm, the wrinkles in the glabellar region disappeared. And that's how they started thinking of using it for cosmesis. This is botulinum toxin type A vial. When he approached 6 different companies, including Allergan, to try to sell the product, and they all rejected. Allergan eventually came back to him and called him and told him, we're interested in selling or manufacturing their product. So they labeled it as Oculinum, and then Allergan also changed the name to Botox, and that's the Botox we know. So how does it work? What's the mechanism of action of Botox? So Botox inhibits the presynaptic release of acetylcholine. So normally we have those vesicles in the presynaptic end of the nerve, which release acetylcholine and then stimulate the presynaptic. I don't know if this works. There's a delay in them. Okay, no worries. So the presynaptic it doesn't really point so well. So the presynaptic, the postsynaptic end of the nerve terminal are stimulated by acetylcholine, and then there will be flaccid paralysis in the muscle. The onset starts within 2 to 3 days, and the maximum effect reaches within 5 days. The duration of action lasts for 2 to 3 months. But how does it change the muscle? How does it work in strabismus? So during the effect of Botox, when you inject Botox, there's a relative contracture of the antagonist is expected to occur, and there will be alteration in the sarcomere number during the effect of Botox. Also, there are some immunohistochemical changes that occur, and there's central adaptive mechanisms. So we hope that the brain will lock the eyes in the straight position. We depend on motor fusion for that to help us with the effect of Botox. Also, there's a traction suture-like effect during the correction period. So all of these together will make the Botox work, and that's how we think the Botox works. There are different common formulas, so it's not only Botox. So there are different Botox is now known. There's Dysport, especially used in the UK. That is Xeomin, and that is Myoblock. In ophthalmology, we only use type A and type B. Type A has the least diffusion, few side effects, and you have to use it within 4 hours if you take it out of the freezer. Dysport, on the other hand, you don't need to refrigerate. Okay, so you can just take it from the shelf and use it. Type B, which is Myoblock, has a greater diffusion, it's quicker onset, and it has shorter duration. So 1 unit of Botox equals 5 units of Dysport and equals 100 units of Myoblock. How do you prepare your Botox? There are different preparation ways. Everybody dilutes it with preserved 0.9 saline. However, the different volume will give you different number of units per unit volume. So the vial comes in 50 to 100 vials, and then you need to reconstitute it before you give it to the patient. You can store it in a freezer, 2 to 8 degrees, for up to 24 hours, or 4 hours in 2 to 8 degrees. And after constitution, you can store it for 6 weeks at 4 degrees. So you can actually mix it and keep it in the freezer. Okay. The volume of dilution added, there are different volumes, and it says there on the box. They recommend using 2.5 on the box. So 2.5 will give you 4 units in 0.1 ml. A lot of us in ophthalmology dilute it with 2 mLs and get 5 units in 0.1 ml. If you dilute it with less amount, a lot of authors recommended diluting it with less amount, so it will not disperse in the orbit, so it will be confined to where you give it. So if you want to reduce your ptosis, your vertical deviations, it's preferable to use 1 ml and then give half 0.05 if you want to give 5 units. Okay. There are many uses for Botox. The non-cosmetic indications are many, but as you can see, the first one was for strabismus and blepharospasm right there. However, where the money is for the cosmetic use, and cosmetic indications are many. FDA approved for glabellar fraud lines and horizontal forehead lines. Okay. These are all FDA approved. It was first FDA approved for strabismus in patients above 12 years of age, and it still is. How do you inject your Botox? There's different techniques as well for injecting Botox into extraocular muscle. The most commonly described are the EMG guided injection or the open approach injection, where you open the conjunctiva and you inject Botox under direct visualization. Which I think is very aggressive, and it defeats the purpose of Botox when it's very minimally invasive procedure. Or you can use the Mendoza forceps guided injection, and these are studied, and I will show you some of the studies. So EMG guided Botox injection, this is an injection into left medial rectus with a 26 gauge needle with electrically sensitive tip and electrode. So you'll first apply the electrodes to the forehead and to the side of the forehead, and then you will ask the patient to look away from the muscle you're injecting. You will insert the needle you will grasp the muscle and insert the needle into the muscle you're injecting, and then ask the patient to pull the eye where you're injecting towards the muscle you're injecting. Once you hear the buzzer from the machine, you will inject. You'll wait for 30 seconds before you retrieve your needle. You pull it out so it does not disperse in the orbit. And that's how Alan Scott used it in his research. This is a video. It's not playing. It shows the same technique, EMG guided injection to the right lateral rectus. I think there's a problem with playing the video. It's basically you ask the patient to adduct the eye, they insert the needle, and then they ask the patient to look in abduction, and then they hear the buzzer, and then they inject. This is a video with a close approach. I was injecting a patient the other day in the OR. So I grasp the muscle, I lift it up, I inject, and then I go forward to make sure that the whole Botox will go into the muscle. So I first go 5 millimeter from the fornix. I grasp the muscle with another forceps. I lift it. I inject pebble down, and then I put my hand up, and then I inject. So which approach should you go for, open or closed? As I mentioned, I think that open approach deceives the Botox being minimally invasive. So I recommend a closed approach, but this paper looked at that question specifically, and they compared closed versus approach in effect, okay? So they had 135 patients, both ET and XT. 31 had an open approach and 104 got a closed approach. They injected 2.5 to 15 units of Botox, and the primary effect was plus minus 10 prism diopters. Their postoperative angles, interestingly, in the open group did not improve as much as the closed group. So in their conclusion, they recommended a closed approach. Okay. This is the Mendoza forceps, and that's a study comparing EMG to Mendoza forceps. The beauty of Mendoza forceps is that you can actually lift the muscle with it, and it really helps. We recently ordered it, and we eventually got it in our institution. We didn't try it. That's why I was injecting with the regular 0.3 forceps in the previous video. But I have received a video through listserv from Dr. Salgado from Brazil, where it was Mendoza is Brazilian pediatric ophthalmologist, and they have been using it for many years. And as you can see, they grasp the muscle, they lift it with this forceps, and then with a 30 gauge needle, they inject directly into the muscle, pebble down, and then she keeps the needle for 30 seconds. With no Q-tip. Okay. And thank you.
Thank you, Dr. Shada, for this informative lecture. Dr. Alan Scott, before his passing, was also working on using Povicaine for strabismus too, and he has published several articles on this topic. So maybe 10 years from now, we'll be sitting here discussing Povicaine instead of Botox. Next, from the Eastern region, we have Dr. Fatma Shamlan. She'll be talking to us about Botox dose response, and she's from Dhahran Eye Specialist Hospital. She's the Chief Operating Officer and the Executive Director of Ophthalmology Service in the Eastern Health Cluster. So, Dr. Fatma.
First of all, and I don't know where is Dr. Shada. I'd like to thank Dr. Shada for her excellent presentation that made my life easy now by giving a detailed history about Botox. So I will go directly to the dose response in Botox. The question, this is the question. First of all, is where do you use Botox? Where is it most effective? And the question is different, but where is Botox most successful? Is it in partially accommodative esotropia, infantile esotropia, consecutive esotropia, or paralytic esotropia? I think this you move it with صح؟ لما قاعد يتحرك. I think we'll get the answer after reviewing several studies. Unfortunately, when you look at the literature for a dose increment in the usage of Botox, or dose-related response, you don't find that much. Most of the studies that have risen for dose response is from Saudi Arabia. There's not much detailed studies elsewhere. The first one is the efficacy of dose increments in botulinum toxin A in the treatment of childhood esotropia. And in this study, the dose of Botox was divided into 2.5 international units for those who had a deviation of 11 to 19. 5 international units in those who had between 20 to 29, so with 10 diopters of increase in the deviation. And then till they reach 10 international units in those who are 40 or more. They studied different cases where you can see infantile esotropia, partially accommodative, sensory, high ACA ratio, Duane, 6-nerve palsy, and non-refractive accommodative esotropia. Most of those patients were either infantile esotropia or partially accommodative esotropia. And the results showed when collectively they saw the response in all of these cases, they found out that those differences is not effective in esotropia. However, what was noticed is that there was a high success rate on those patients, or not high success rate, let's say percentage, in those patients, in 59% in those with partially accommodative esotropia and 29% in those patients with infantile esotropia, which was comparable to the other diagnoses that were there. It was a bit significant in percentage. In another study, which is the comparison of those increments in botulinum toxin A in comparison with surgery as a primary treatment for infantile esotropia and partially accommodative esotropia, again, the doses were divided into an increase of 2.5 for every 10 diopter increase in deviation in infantile and partially accommodative esotropia. And it was compared to a recession for the angles that are seen here, where 20 to 24 was 4 millimeter, 25 to 29, which is a difference of 5, let's say approximately 5 to 4, is 0.5 millimeter in recession. The results showed that there was a successful outcome with higher patients who underwent increment doses of botulinum toxin after the first injection. And that was with mostly with the cases that had 2.5 international units of botulinum toxin, and with the smaller angle of deviation rather than those with the large angle. The least successful rate was those with 10 international units for those who were 40 or more in deviation. It was also found that the result of increment doses of botulinum toxin in infantile esotropia was comparable to surgery. So when you compare surgery to Botox, even with the 10 international units where you're expecting infantile esotropia to have large angle of deviation, the botulinum toxin was comparable to it. Even though there was no statistical difference between botulinum toxin injection and surgery in infantile esotropia, bear in mind that botulinum is less invasive. Anesthesia that's required for those patients is also less invasive, and cost effectiveness of giving botulinum toxin is way cheaper than going for surgery. So you might consider giving Botox for 2 reasons, either to treat if it is comparable to surgery, or to even debulk the angle if the angle is too large for recession, let's say. Now, in partially accommodative esotropia, patients in the botulinum toxin group had 2.9 times, almost 3 times more successful rate than those who went to for surgery or by medial rectus recession, with the clinically significant rate. I think you have a study, صح? It is comes with this. Okay, good, excellent. So I think in conclusion, in general in this, and I think I skipped something. Okay, I think in this one. Okay. A patient هذه قلناها. Okay. The increment doses of botulinum toxin injection in correlation with the angle of deviation is comparable to surgery, as we said, in infantile esotropia, and it is more successful in partially accommodative esotropia, where also what they found is that there was 0% consecutive exotropia in those who had, when we say consecutive exotropia, we're talking about long-term consecutive exotropia where it needed surgery, not that transient one that might indicate the successful injection of esotropia. The third study is factors affecting the efficacy of botulinum toxin injection treatment in infantile and partially accommodative esotropia. And this study was aimed to determine the rate of predictive factors for success of botulinum toxin in infantile esotropia and partial accommodatropia in Saudi Arabia, Riyadh, and to analyze the association between success rate and different botulinum toxin doses. Now, in this study, the comparison between less than 10 botulinum toxin injection, 10 to 24, and more or equal to 25. So those increment doses that we were comparing between 2.5 till 10 were not were within the less than 10 prism diopter. Sorry, less than 10 international units. It showed that smaller angle of deviation presented with and transient overcorrection after the first week of injection were associated with higher success rates. And this comes with the other studies that stated that 2.5 international units were giving a higher success rate than when you increase the doses. There was no significant differences in the success rates between different botulinum toxin doses. But if you notice, it was between less than 10, more than or 10, and more than 25. So even if there is no significant differences, cost effectiveness wise, then using less than 10 international units will give you the same result as giving 25. So it goes with the previous studies stating that giving increments, cost effectiveness wise, less invasive, less complication, would come handy in comparison to giving a higher doses of botulinum toxin. Now, in conclusion, we would say that botulinum toxin dose increments seems useful in the most cases of partially accommodative esotropia, followed by infantile esotropia. And this might be because the deviation in partially accommodative esotropia come with the study that reaches approximately 35. It's a moderate deviation of angle and compared to infantile esotropia. That's why the success rate is higher. Plus, there is the accommodative part that works hand in hand with botulinum toxin in comparison to the cases where you have the infantile esotropia. Now, the other thing that we were discussing, myself and Dr. Shada, that most of the studies that came up and what was noticed, that doses beyond 7.5 international units were not that successful. Part of it could be an explanation that beyond 10 international units were given to 40 and more, regardless. The increments were not used. But even those who were, it was not studied between 40 to 50 and what we will do when we increase the increments. Considering that most of us, when we're using it, we're using the maximum is 10 international units in Saudi Arabia. We don't go beyond. Some of us go beyond. But this comes with the study that was presented that doses beyond 10 would not give you the effect in comparison to surgery. Then surgery is an option. So you might consider that, and you have cases more than 35 prism diopter of deviation, option of surgery might be handful to decrease the failure in those cases. I think I'm done. Thank you very much.
Thank you for being on schedule also. I'd like to present Dr. Saif Al-Abaisi, who's a consultant at King Abdullah Specialist Center or Hospital. He's also the fellowship director, and he's also my chairman in the committee for the Pediatric Ophthalmology and Strabismus Fellowship at the Saudi Council. His talk today will be about Botox and exotropia. Go ahead, Dr. Saif.
Yeah, okay. Assalamu alaikum. I'm going to talk about the use of Botox for exotropia. Of course, as we know, the use for exotropia is much less than its use for esotropia. Yeah. Okay. So first of all, briefly, I'm going to talk about the exotropia, which can present in different types and different ages. As we know that it can present as congenital, intermittent, convergence insufficiency, consecutive, also sensory. The botulinum toxin injection have been tried in this treatment of most of cases of exotropia in general. First of all, I'll talk about intermittent exotropia, as it is the most common form of exotropia in childhood. The non-surgical management is usually not very effective, but preferred over surgical treatment for young patient and a small angle with a risk of overcorrection and some of high ACA ratios. Surgical management is usually indicated in deteriorating intermittent exotropia or otherwise losing binocularity. Another treatment option is the use of botulinum toxin injection to treat intermittent exotropia. The therapeutic principle of botulinum toxin in strabismus in general is to paralyze the injected muscle. So the antagonist muscle will not have counteracting power. The side effect is known for everyone: global perforation, which is very rare, and transient ptosis, temporary consecutive deviation, and induced vertical deviation. This is a study has been done by Mohammed Rivasi. It is a case series studies for use of botulinum toxin in the treatment of intermittent exotropia. They included 21 patients with intermittent exotropia at different ages, but the angle is less than 40 prism diopter. And they studied the outcome of the Botox in this patient, and the outcome showed success rate of around 50%. This is his study. As you see, there is a statistical significant difference in the Newcastle control score, which is have changed from 4.4 in the pre-injection group to 1.4 in the 6 months follow-up period. Just to show you, to tell you what is the Newcastle control score. This is a score to evaluate the deterioration of intermittent exotropia. It's a new classification or evaluation score. If you score more than a specific number, it indicates that there is a deterioration. So once the number decreased, it means the control improved. So it changed from 4.4 to 1.4. And also the angle of deviation has changed from 30 plus the pre-injection group to 11 prism diopter at 6 months follow-up. Also, there's another study in the studying also the use of botulinum toxin in the treatment of intermittent exotropia and its factor affecting the treatment. And this is a recent study. Also, the study have included 74 patients. And in the study, the success rate, as you see, is 56%. And the factor affecting the treatment is the angle of deviation. If it is small, the success rate become better, and also the dose of injection. Here's also, it's another study, and this one comparing the Botox to surgery. And as we see here in this study, there was 2 arms. Each arm constitutes of 72 patients. And in this study, there is no significant statistical significant difference between the Botox and surgery in the success rate regarding the correction of the angle of deviation, but there is a statistical significant difference in the fusional control restoration between the Botox and the surgical group, toward the surgical group, of course. Now I'll talk also about the convergence insufficiency group. The convergence insufficiency, it is the type of deviation when extrovia at near is more than distance by more than 10 prism diopter. Again, also non-surgical management is usually targeted first, which include vision therapy, home-based pencil push-up, computer versions therapy based in prism, and finally surgery. Botulinum toxin also has been tried in the treatment of convergence insufficiency. This is also another study studying the effect of botulinum toxin in the convergence insufficiency extrovia group only, and this which has been received any type of non-surgical management or even surgical management. In this study, the success rate, first they have included 23 patients, and they studied the success rate in the first and the last follow-up. And as we see in the first follow-up, the success rate was 57%, and the last follow-up it reached to 23%, which indicate that there is still a room, or there is still a chance of help for Botox for even cases of convergence insufficiency. Now also I'll talk about consecutive extrovia. This is a type of deviation that has history of extrovia treated with Botox or surgery and subsequently convert to exodeviation. Surgical management is much preferred over botulinum toxin injection if the previous intervention was surgical, as we know, because of scar formation and slippage. But it can be considered when strabismus surgery was undergone in all was done in all horizontal muscles, or if the patient has sensory deviation, for example. Also, sensory extrovia. It's usually developed in older children or adult if one eye has poor vision. The treatment of choice also it's a surgical intervention, but botulinum toxin make a good alternative. It can be repeated multiple times to achieve an acceptable result. There's a study done in Kekish. They have included all types of extrovia. They have included 97 patients, and they divided the patient according to the type of deviation, if it is consecutive, sensory, or basic type. And in this study, the success rate was also good, and it shows some improvement of some of the patients with sensory deviation. I'll show you the there is two column. The first column is the patient who achieved correction to within 10 prism diopter, and the second column is the patient who received, who achieved the correction to 20 prism diopter at the last follow-up. And in this column, it shows that there is also an improvement in the sensory deviation and also in the consecutive type. The success rate, of course, in sensory extrovia is the worst among all different types, and the best outcome was achieved in basic and consecutive type. Finally, as a conclusion, the Botox represent a possible safe alternative to surgery in the management of many extrovia types. The children's binocular visual function can be maintained through the recovery of fusion. Is not as good as surgery, and botulinum toxin has a promising application because of its simplicity, reproducibility, minimal invasive, and low requirement for anesthesia care or reliable and also reliable safety. Thank you.
Thank you, Dr. Saif. For questions, please keep them for the end. We'll have a 10 minutes period for discussion. Also, you can write them down on the poll website, or you can write them down online if you are joining us through the web. Yeah, and the Q&A section instead of the chat section. Next, we have Dr. Hanan Niaz. She's our current fellow at King Saud University, and she'll be talking to us about Botox augmented strabismus surgery.
Good morning, everyone. Today I'm going to talk about augmented surgery for treatment of large angle infantile esotropia. So infantile esotropia is a newborn deviation of the eye that manifests before 6 months of age. The usual surgical strategy when the angle of deviation is large is either to operate in 3 horizontal rectus muscle or perform supramaximum bilateral medial rectus resection. With both of these techniques, there is short-term success rate. However, in long term, there is risk of overcorrection and exotropia. So alternative to this, botulinum toxin is a treatment option that had potential to potentially effectively in treating infantile esotropia. However, it requires several injections, and when the preoperative angle of deviation exceeds 30 prism diopter, there is low chance of success. Considering the limitation of both technique, it has been recommended to combine strabismus surgery and botulinum toxin as a primary therapy for large angle infantile esotropia. So in 2019, Dr. Michael Wan has published this study, which was about the effect of botulinum toxin augmentation on strabismus surgery for large angle infantile esotropia. It is a retrospective, non-randomized comparative case series study at Boston Children's Hospital from the duration of 2002 to 2014. He had 2 groups. The study group was the augmented surgery, which includes all patients who underwent botulinum toxin augmented with bilateral medial rectus resection, regardless of the angle. The comparative group was the surgery-only group, which include all patients treated with traditional bilateral medial rectus muscle resection. However, with the preoperative angle more equal 60% diopter. They exclude all patients who had less than 4 months of follow-up, preoperative vision loss except for amblyopia and history of neurodevelopmental delay. The main outcome was the surgical effect on alignment 4 months after surgery, which was expressed in change in alignment in prism diopter per amount of surgery in millimeter. Second, they look for the surgical effect on alignment at 1 year after surgery, the change in alignment between 4 months and 1 year, and the augmentation effect of botulinum toxin injection compared to the net effect of traditional eye muscle surgery. Based on the primary and secondary outcome, their overall was to look for developing a dosing table for botulinum toxin augmented surgery. So they included 30 patients in this case series. In the augmented surgery, the number was 14, and in the surgery-only group, their patient were 16. At baseline, there was no significant difference between both groups. They both had preoperative deviation of 67 in the augmented surgery and 65 in the surgery-only group. So in the result, they found that the mean amount of recession of medial rectus was 5.5 millimeter in the augmented surgery group and 6.1 in the surgery-only group. The mean dose of botulinum toxin was 3.7 units per medial rectus muscle, and it was ranging from 1.75 to 5 units. In the augmented surgery group, they had 86 of transient overcorrection and 50% of transient doses. Both of this resolved in 3 months, and there was no major complications. For the main outcome at 4 months, the mean change in deviation was significantly greater in the augmented surgery group, 5.7 prism diopter per millimeter, compared to the surgery-only group, which was 4 prism diopter per millimeter. At 1 year, they found that the effect remained greater for the augmented surgery, 5.4, compared to the surgery-only group, 3.7 prism diopter per millimeter. From the duration of 4 months to 1 year, we can notice that there was slight reduction of the surgical effect, which was more in the surgery-only group. However, this was not statistically significant. For the effect of botulinum toxin dosing on the surgical effect, they represented linear regression figure, and there was positive correlations between the Botox dose and the surgical effect. However, this was also statistically non-significant. From the outcome format, the author could create a surgical dosing table for augmented surgery, and this was the table they recommended if the augmented surgery was performed. For surgery on a group, they didn't recommend a recession more than 7.5 millimeter. So, in this study, using botulinum toxin augmentation, the mean surgical effect was greater than the surgery alone by 1.7% drop per millimeter at 4 months. The degree of augmentation was almost identical at 4 months and at 1 year after surgery. Considering the transient effect of botulinum toxin, it was suggested that the augmented effect of the Botox was due to permanently alterating the structure of media rectus. In addition, they also suggest that the early alignment and augmented surgery give the child a chance to regain good motor fusion, which add to the long-term effect. So comparing it to other surgery, for supramaximal bilateral media rectus recession, literature found that successful short-term, however, it was associated with the risk of overcorrection long-term. Dr. Kushner, in one of his studies, suggested that if media rectus are recessed more than 1.5 millimeter beyond the equator, it can lead to undercorrection and later progressive overcorrection. And one long-term study showed 30% rate of overcorrection. Comparing it to 3 muscle surgery, also literature found that it reported good short-term success rate. However, there was late progressive exotropia and high rate of overcorrection. In addition, 3 muscle surgery also leave only one unoperated horizontal rectus muscle for further intervention if needed. So what about augmented surgery? For augmented surgery, Dr. Khan, 2005, he published a case series that include 8 patients. He found success rate of 75%, and the mean follow-up was 10 months. Dr. Leder in 2012 published a study that include 23 patients with large infantile esotropia, where he performed bilateral media rectus recession of 7 millimeter in addition to Botox. The success rate was 74%, and the follow-up was at least 2 years. In concurrent to this study, Dr. Wan has published a 2-center comparative trial for comparing the success rate in patients treated for large angular esotropia with a mean follow-up of 3 years. They included 88 patients. Most of them underwent bilateral media rectus recession. 15 had augmented surgery, and 3 had 3 muscle surgery. They found the success rate was significantly higher in patients treated with augmented surgery, 48% versus PMR recession, 18%, or 3 muscle surgery, 32%. They also found that the risk factor, the success rate was associated with the type of surgery. Referring to the dosing table, the dose of botulinum toxin in this table was not included in the table because the botulinum, the correlation between botulinum toxin dose and surgical effect was not found to be statistically significant. However, the author recommended a dose of 5 units of Botox to achieve the result in the table. For the complication of Botox in augmented surgery, it was associated with transient overcorrection and ptosis. And we didn't want that there may be a short-term adduction limitation that masks a slipped media rectus muscle. So be aware of that. So this study has several limitations. The amount of media rectus recession and the dose of botulinum toxin was determined by the treating physician. Standardizing dosing table were not available for augmented surgery in this study. And since the surgeon injected botulinum toxin before the surgical incision, were other injected with direct visualization. And the concentration of botulinum toxin injection was varied. So in conclusion, botulinum toxin injection can augment the effect of medial rectus muscle. It should be considered as a therapeutic option for large angle infantile esotropia in order to prevent the late risk of overcorrection that come with the recession of supramaximal medial rectus muscle and 3 muscle surgery. Thank you.
Later on, but it gives me the pleasure now to introduce Dr. Amar Khan, who is a qualified pediatric ophthalmologist from KKH. He decided to be have another fellowship in corneal external disease. So he's an FT now in at Prince Sultan Medical Military City as well. He will be talking to us about Botox in use in the sixth nerve palsy. Dr. Amar.
Assalamu alaikum warahmatullah. Good morning, everyone. I would like to thank Dr. Amal and Dr. Rashada for the kind invitation. I will speak about the sixth nerve palsy and Botox injection. So let's start by this question. What are the indications for utilizing Botox in sixth nerve palsy? Is it for prophylaxis? Is it to cure the esotropia? Is it for maintenance? Is it for adjunctive to surgery? Is it for diagnostic purposes? You can choose more than one if you want. I think most agree that it is used as adjunctive to therapy, and the other indication that is mentioned here, not all of us agree upon it. So let's see what we have in the literature about this. So the management, in summary, regardless of the Botox, the management of sixth nerve palsy that we wait for spontaneous recovery, which occur in 70% of the cases usually. Okay, so if after 6 months recovery does not occur, usually we look, is it partially sixth nerve palsy or it is total palsy? So if it was partially, we usually work on the horizontal muscles. And if it was fully sixth nerve palsy, we usually use the transposition. Okay, so where is the role of Botox in this algorithm? Let's look about the sixth nerve palsy. So we have here a muscle that has no nerve supply. It's totally paralyzed. Usually with time, it starts to become atrophic, and with time, you will have more esotropia. And with time also, the other muscle start to become more stiff and more short, and this is what we call contracture. So the question is, can we treat contracture or prevent contracture by giving Botox? This question was asked by the father of Botox, Alan Scott, in 1985, and he studied 17 patients. And he studied 17 patients. 4 of them, he used this indication, which is prevention of the contraction. And actually, he gave the Botox 8 weeks after the onset of the sixth nerve palsy, and he noticed that 3 out of the 4 patients recovered without a contraction. This is another study talking about the early and late Botox toxin injection. They gave 10 patients a Botox, 6 of them within the first 8 weeks, and this is again to prevent the contraction. And other 4 patients were treated after 6 months. They have no contraction by forced duction test. So they found in the patient who were treated in the early 6 months, in the early 8 weeks, sorry, the 5 of them gained fusion. So they gained fusion, and none of them complained of reversal of diplopia, because some studies talked about the presence of the issue of reversal of diplopia. When you paralyze the medial rectus, the patient will have this issue. So none of them complain about this. While in the four patients who were injected later after 6 months without the presence of contracture, no one improved. And actually, one of them, they noticed the presence of overcorrection. So they concluded that giving the Botox for 6th nerve palsy in the acute phase is beneficial. Another study talking about the acute unilateral 6th nerve palsy, they enrolled in 29 patients with acute 6th nerve palsy again. They gave the injection in the first 40 days of onset of the symptoms of 6th nerve palsy, and the follow-up was for 14 months. Before the treatment, there was an esotropia around 45 prism diopter, and after the treatment, 22 of the 29 patients, or approximately 76%, improved, complete recovery. And 7 patients had fusion in the primary position, and 3 patients has fusion with prismatic, and 2 patients needed subsequent surgery. Even for those patients who needed subsequent surgery, there was no contraction. So what about a study comparing Botox versus no intervention? So this study, it was a clinical trial including 34 patients with acute 6th nerve palsy treated with Botox. The control group was 52 patients not treated with Botox. So 34 with Botox, with 52 control. Most of the majority was due to traumatic causes. Other etiologies also, etiologies like cardiovascular disease or cerebrovascular, sorry, or tumor or diabetic. They followed the patient 11 months after the injection. So in the control group, only 30% recovered spontaneously without only observation, with only observation. In the Botox group, so for the unilateral survival patient, 90% fused alone without or with small prismatic correction, and 10% required surgery. For the bilateral, 36 from the Botox group recovered, while 64% required surgery. So they concluded that the Botox is useful to eliminate the symptoms in the early phase, eliminate the diplopia and abnormal head position, and it prevent the contraction. And even if the surgery becomes necessary, that you don't have contracture, you can operate on less contracted muscle. There was an argument, as I said, about the confusion of the confusing reversal diplopia. In their study, they did not find this an issue with their patient. Actually, their patients were appreciating the diplopia free and the fusion without the need of marked head turn. What about a randomized, prospective randomized trial? This was published in the Journal of Pediatric Ophthalmology and Strabismus. They enrolled 47 patients, 25 were controlled, 22 were injected with Botox, and the follow-up range from 7 to 42 months. The injection was in the first 3 weeks. So after 4 months of the entry of the trial, full recovery was observed in 72%, including both group. The non-recovery rate was 20% in the control group, while it was around 4.5% in the Botox group. This is another major article. It was a multi-centered study. All members of American Association of Pediatric Ophthalmology and Strabismus and North American Neuro-Ophthalmology Society were enrolled involved or invited to enroll patients, and they collected 48 patients, 62 patients treated conservatively, and 22 patients treated without with Botox within 3 months. And this study concluded that there was no significant difference between the Botox and the control group. Okay, can we treat after 6 months? This patient is having left 6 nerve palsy, maximum limitation of abduction. Patient cannot even cross the midline. So what are we going to do? Are we going to do surgery or R&R? 3 muscles, 3 horizontal muscle, or vertical plus medial rectus, or only Botox? Can Botox help in this situation? Let's see. Back to our example. We have the medial rectus here contracted, and the lateral rectus is paralyzed. After a period of time, you will have the medial rectus will regain its function, but it start to work against the contracted muscle. So you might have more is to be related to the contraction, not only to the recovery of the muscle. So the question is, can we treat this contraction after 6 months with Botox without the need of surgery? Again, Alan Scott, the father of the Botox, he studied in his first study in 1985. He enrolled 12 patients with the presence of contraction, treated later after 6 months, and 6 patients regained single binocular vision. And in 5 patients, injection was used prior to muscle surgery and eliminated the contraction in all of them. The contraction reoccurred during the surgery. And all of these patients, when he needed to do surgery, he did not do ipsilateral medial rectus recession, as he already did give Botox. This is another study talking about the treatment of complete or partially recovered chronic 6 nerve palsy. And they treated 22 patients with Botox after more than 5 months of the onset of the 6 nerve palsy. 41 significantly improved, and 59% had modest improvement and required surgery. Now, is there any other way of giving Botox or use of Botox to treat 6 nerve palsy? As we said, adjunct to surgery, you will relieve the contraction. So you will work later on the free medial rectus. You can decrease the need of operating on 3 vertical muscle and decrease the risk of anterior segment ischemia. And actually, you can give it near the time of the surgery or few weeks earlier. So back to our example, this patient was from the first paper of Dr. Alan Scott, and he gave Botox, and this is the picture after giving Botox. In the middle, there is limitation of abduction and adduction, but he's ortho in primary position. While in the lower 3 photos, this picture after the surgery, he did 5 weeks after the Botox, he did surgery. And this is the picture 6 months later, where the patient is ortho in primary with single binocular vision in the 10 degrees to either side. Other uses of Botox is to diagnose. So sometimes you don't know, is this partially or complete? If you release the contraction, you will know if the medial rectus is working or not. The other way of using it as a diagnostic, sometimes you have patient with severe RTA, massive cerebrovascular accident. Sometimes they tend to have central disruption of the fusion. So how you would know before doing any surgery that the patient will fuse or not? You can give Botox and see if the patient can fuse. Then you can discuss with the patient the possibility of surgery. Other indication is the maintenance. Sometimes you have patient who is unstable to go for surgery. For example, in this paper, they treated patient with severe bronchiectasis or rheumatoid heart disease or arteriovenous malformation with Botox for the sixth nerve. The other, sometimes you have inoperable lesion, like, for example, intracranial lesion or intracavernous giant aneurysm. In both groups, the patient will have diplopia. Sometimes they need permanent occlusion. Sometimes they need marked fast tear. So by giving Botox, you can help them. In conclusion, Botox can use to treat contraction in the chronic phase and to prevent contraction in the acute phase. And also it can be used as adjunctive to surgery and as a diagnostic or maintenance purposes. Thank you.
First, I would like to thank all the speakers for their great presentations. You all make Botox sound so wonderful. I want to use it for everything. By the way, this was not sponsored. None of the lectures and none of the speakers is sponsored by any of the Botox producing companies. So we will open the floor for discussion. Perhaps first we will start with the online questions, and then we will take questions from the attendees.
Thank you, Dr. Man. We have a question here from Dr. Ghada. She's asking about the dose. Are these doses 7.5 international unit per muscle or the total for both media rectus? I guess this is for Dr. Fatima.
The doses per muscle. So 7.5 international unit for each media rectus.
So what I understood is that you, in your talk, you mentioned that more than 7.5 units is of no use.
Yeah, not of not use, but the success rate of it is lesser than those who are in 2.5 in comparison to 2.5 or 5 international units, 7.5 international units.
Can I say something? We have looked at our patients with infantile esotropia, and we looked at the dose response curve for those patients in particular. And we saw that after 7.5 of Botox, the dose response curve just plateaus. So the more we gave, it didn't change on the effect. I think it just disperses in the orbit and it does not really make any more effect. So 2.5, 5, and then 7.5, there was a steep increase. And then as you go after 7.5, there was just a plateau.
And does it matter? Are you injecting the medial or the lateral rectus?
I don't normally inject the lateral rectus. I don't think Botox is effective in exotropia. We'll have to conduct a study to... No, not in sixth nerve palsy. I'm not talking about sixth nerve palsy. I'm specifically talking about exotropia. So I have no experience, actually. I reviewed the literature and the literature is not supportive.
Do you want to answer?
Yeah. Actually, there was not much of literature review studies I found when I reviewed the topic, but the few studies have been published. It shows acceptable success rate reaches up to 50% in cases of intermittent extropia. In other types, it's much less, of course. It can be used as alternative, especially if sometimes you have been trying the surgical option, or in cases of young children who have a small angle, you are afraid of overcorrection, because the risk of overcorrection in Botox is very, very low. But I think, yeah, we need a randomized controlled study with a large number of patients included. I think it has a room for use.
That's great. And that's why we have the second session where we'll be debating who's with and against Botox. So it'll be even more heated than this. I have a small comment about the amount of Botox that can be injected. I agree with Dr. Shada. I rarely or almost never inject more than 5.5 units. And because I think there is just so much volume that the muscle can handle. If you inject more, then everything will just go everywhere and probably cause more complications than benefit.
Yeah, and regarding using Botox for exotropia, I actually think if we would try using Botox for exotropia, it would be in the adult population because it's a short procedure. It can be done in the clinic, and in a child, I would like to go more precise. I want to know how much I'm correcting and titrate my surgery. But for an adult, probably it can help, especially in intermittent exotropia, as it's an office procedure.
On the contrary, what would you do with a patient who is less than 1 year old and he has an angle over 50 of an XT, which you cannot check accurately because he's so uncooperative? What would you do for him?
Well, there was at the APUS meeting, they were talking about surgical dose tables, and they think that the surgical dose tables don't really affect the muscle. It's just the weakening and the recession and the resection, and I believe that so much. So I try my best to get the measurement to be more accurate, but if I'm not lucky, then I will go with whatever I get with Hirschberg. I try my best. I mean, I'm a pediatric ophthalmologist. I went into this field knowing, I know that this will be an issue. Cooperation of the patient is an issue, but I tried my best. I use all my skills to measure the angle and then wish that they would respond the way I want.
Yeah, in addition to that, what I notice also, I'm becoming practicing with time, and also I saw also many of my colleagues in the field doing the same. In cases of a difficult child who is not cooperative at all, they tend toward preferring the lesser or the smaller possible accurate measurement. For example, if you are in doubt between 40 and 30, they prefer 30, because when you go with lower measurement, the risk of overcorrection, the risk of complication is much less. Of course, also, if it is not accurate, it will end up in residual or undercorrection. But this is one example. And also, sometimes if the case is not necessitating an urgent intervention, you can just wait, and better to do it at the correct time than doing it in a wrong way.
Thank you very much for the nice presentation and review. I just two comments. One of them regarding the dose, and I agreed with you that I think larger dose doesn't give more effect. This one thing, but you cannot say that larger dose has less outcome or more failure, because usually we give larger dose in the larger angle, which knowing that is not responding well to Botox. The second point, I think it's very important one, is when to start recording your outcome. I don't think anyone should report or include cases in his study less than about 6 months from the injection, because we are seeing changes. Yes, the chemical effect of the Botox is weaned within like 3 months, but alignment take time till it stabilizes. So up to 6 months and sometimes even 8 months, you still see changes. So if you include this patient in your study, then you are biasing your study and you end up with having like more outcome of Botox and more success rate, more than what you expect. So I think always, if you want to conduct any study, just go and report your outcome starting from like at least 6 months or 9 months and onward.
Can I say something? I think Botox depends on re-injection. So that if you want more effect, you need to re-inject the patient. It's not increasing the dose, in my belief.
one of the studies that with the dose increments, one of them was considering it's a failure after the first injection. The other one considered the success rate after second injection and third injection, maximum 30 injections. And the success rate went higher with an augmentation dose after 6 months. If there was no result after 6 months, then a second injection, and the second injection was way lesser in dose than the one that was used in the first. So partial success is there even with Botox. The other thing, considering the child who's uncooperative and having 50, I think rushing into surgery is not a good option from the first visit, even in pediatric patients. We have to take, again, pediatricians, pediatric ophthalmologists, we have to take our time with the patient, and uncooperative patients in the first time in the clinic, he would be fearful. The environment is very scary for him. So I think a second visit, even if a recent visit, for him to get familiar to the environment would get you the angle that you want. Usually when I decide on surgery, for me, at least, if it is an urgent case, I would take 2 consecutive angles that are similar to each other. Usually I take 3 consecutive angles that are consistent before deciding on surgery. In exotropia, unlike Dr. Saif, I'd like to go for an overcorrection rather than an undercorrection in XT, because eventually they would go definitely for an undercorrection. Again, I hate exotropia when I compare it to esotropia. I love esotropia and the results of esotropia.
I don't think you can compare exotropia to esotropia. All surgical dose, or at least the surgical dose table that I follow for exotropia gives a 5 to 10 of overcorrection. So I intend for overcorrection, and I think you cannot compare apples to oranges. It's totally different. When we talked about the augmented Botox for strabismus, that's when I actually use Botox. I don't add a third muscle when I have an infantile ET of 70. I just inject Botox and do a BMR. And I think it's useful. Botox has a role in esotropia, but I think that you have to be selective. I use it in augmented surgery, as I mentioned.
Can we just move to another question? This, I guess, for Dr. Khan. The question says that in the sixth nerve palsy prior to Botox injection, do you consider the primary angle or the secondary angle of deviation?
Usually, in all the studies, they consider the angle while the patient is fixating on 6 millimeter, while the non-paralytic eye is fixating.
So you take the secondary. Thank you. Another question from Dr. Mordi. Regarding Botox augmented strabismus surgery, I usually do it in 2 sessions. First session, Botox to decrease the angle, then strabismus surgery for the residual angle. I think this way better than both the same session. Do you agree? Staging.
So for me, I actually do it all at the same time. I do the BMR and then I do the Botox injection and the direct visualization during surgery. It's just it makes more sense to me because it has less anesthesia. So instead of putting the patient under anesthesia twice, I just do it all at the same time.
I do it not under direct visualization. I do it before I start my surgery. I think this way the Botox is more confined to the muscle, so it doesn't disperse as much. I don't know.
Before the session.
I don't do it. So even if I'm doing surgery, I don't do it open. I do it closed as well.
Before you recess. Okay. I do it differently. I do it after I recess.
Just one comment here. I think if you want to inject under direct before with the recession, inject before you disinsert the muscle. Because after this insertion and this suturing, the muscle become too much back and not easy to reach the muscle and inject inside it. So if I inject with the surgery, after suturing the muscle and hooking it, I inject inside the muscle before cutting the muscle.
That's what I believe too, because I think if you inject before, then with the manipulation from the surgery itself, you may lose some of the Botox during surgery. But your point is valid. After you open the capsule, then of course it's not as contained. But if you inject before, then you're still going to open the capsule after, and so you may go back and forth. But yes, Dr. David Hunter taught me this, and I always do it after any Botox injection, just to reduce the amount of Botox that can go to the levator muscle.
How long do you do that for? For the elevation, head elevation, usually?
So if I'm injecting Botox only, I keep the head 45 degrees till he's in recovery. Yeah. Yeah, till he's in recovery. So yeah, till they leave. Yeah. In adults, I probably have them sit up right away. Yeah.
I have also adopted the procedure of wrapping the patient after the injection for 1 to 2 hours if he's very active and impossible to control. And I also request the parent to put the patient to sleep at home at 45 degrees for the next 1 to 2 weeks. And I almost never get ptosis post injection. This is my maneuver.
I think there are multiple tricks to decrease the ptosis. So if you dilute the Botox with 1 ml instead of 2, that will help as well. And if you keep the head 45 degrees up, I think they help. Yeah.
I have tried the Botox for in clinic for few number of patients who are adults. And I noticed in this patient, the amount of ptosis is much less than the amount of ptosis I see in children received Botox under general anesthesia. Probably the instructions I give to adult patients probably make difference. I usually tell them not move from bed for 2-3 hours or 4 hours. I think injecting the Botox subconjunctivally near to the muscle will eventually diffuse to the muscle, and it will not go to other structure if the patient is lying down on his bed, on his back, sorry. In addition to that, as Dr. Shada mentioned, decreasing the amount of Botox given. If you only mix it with 1 cc, you make the dose 10 units per 0.1. This will make it more concentrated, and you need less amount of Botox as to be given, not as unit, as a volume. So maybe these precautions can help.
The last question here on the Zoom line is how many times we can repeat the Botox injections?
Before surgery, I think that's what it says. I think 3 is the recommended. So you should tell the parents that you need multiple injections. When you consent them for Botox, you should tell them that this is not a one-time procedure. It requires multiple injections. And I think the maximum you would go for is 3 injections before you say that this is not working. We should try something else.
In my experience also, I think Dr. Salih Al-Misfir has, I think he's the most experienced one here in the theater with Botox, and also Dr. Shamran, the other colleague also. But in my experience, I found that it's not related to the number of Botox to be given to the patient. It's related to the effect. So if you properly injecting Botox and also properly you see the outcome later on, if you give him an appointment 2 weeks or 3 weeks or 1 month and you saw outward deviation and ptosis, then the Botox has started its action. And if later on the patient returned to his previous angle, I think better not to repeat Botox again. So this is only one time. But sometimes what happens, you don't see the strong effect. You see the patient instead of consecutive deviation, you see the patient only ortho. So you know that you didn't give a good amount or a perfect way of injection. So you need to repeat it again a second time. But third time, I disagree, except in cases of improvement. If you see improvement, let's say that the angle was 50 and become 30 and then it's become 20, you still can go for third injection.
I've actually had parents who were not, I was not able to convince to go for a second dose because they were so scared of the ptosis and the overcorrection that they had after the first injection. So it was very hard.
Assalamu alaikum. Say if he would like me to comment on how many times you have to inject a patient. If the patient family reached the level of a trust in you, they will allow you to go injecting him as much as you can. But you have to be very fair with your patient. There is multi-factor that will give you the effect. First, the preparation. Is it prepared in proper way? Sometimes you will give the injection for 5 patients and you will see all of them without much effect. This means the preparation, there is something wrong with the preparation. Second, the volume that will be injected. Second, as mentioned by Saif, if you find good effect, a consecutive deviation after the injection, this means there is a good effect. If you didn't see and you encounter the same finding with other patients, that means the preparation was not in the proper way. Some of these patients, they have antibodies. For this reason, they will not respond to your chemo. Denervation by all means. Even if you give high volume, the effect is not much. I prefer to go with 3 doses, as mentioned by Shada. If I find the reason to augment with 4th dose, it will be okay. But usually, I limit my plan with the 3 doses.
Do we have other comments or questions from the people in attendance, please?
Assalamu alaikum, good morning. Thank you for the organizing committee. Thank you for the speakers for this is very interesting topics. I just have one question for the committee or for the attendance, that if you give for a partially accommodative esotropia and it was large angle and you give 3 doses of Botox and still the patient didn't improve, having some residual, would you go for the same schedule or you are going to reduce the amount of recession?
I think you have to wait for the second session to answer this question.
Okay, thank you.
We'll talk in detail.
And I just want to add one information that during I was doing some cases of doing treatment with Botox for some cases, and I was having good outcome. And suddenly I was not having any successful injections. I discovered that the nurses, they were putting Vigamox drops after the injections. And all of the cases, they were not successful with me. And then I stopped it. By themselves, they used to put the drops. They think this is something like a prophylactic of giving Vigamox. And when I stopped it, then I was having good outcomes with that.
I'm not sure if this has any relation with your injection, with the result of your injection. Maybe, as Dr. Salih mentioned, maybe it's the preparation.
No, it was by me, but you know, every after surgery they used to put ointment, like after with clothing.
I'm not sure if we agree that this is, but it's a good observation, anyways. Yeah. Also you have to make sure, because sometimes the nurses will shake the bottle for you. So this one might be something else. I have tried it myself, you know. One time I had one patient who had just gave 1 shot of injection, 5 units each. So I said, okay, I have some lines in my forehead, I will use it. So I went home and my daughter gave it to me. And to my surprise, everything was the same. So I was wondering, oh, so maybe the same thing will happen to the patient. Maybe he'll have no effect. And it's true. The patient came as if he had no injection. So maybe there was something wrong with that particular preparation or bottle. It was expired.
No,
and also pay attention that you have to, if you use the preservative saline, then you can keep it for 1 day. If it's the BSS, the saline. Yeah, don't you use it for the 24 hours only? If the saline has preservative. But the ones that are in the OR, the small bottles of, they are not preservatives. So then you have to use it 24 hours, right? Okay. Good to know.
Maybe we'll take the last question.
I just have a comment regarding what's now presented. We can see that Dr. Shad Al-Farehi, this is Dr. Abdullah Khan. We can see Dr. Shad Al-Farehi, she mentioned that she noticed with the small dose, the effect is good. And also we noticed that with the XT, intermittent XT, the effect of Botox is good. So is it really the dose? I really want to emphasize is about stereopsis or like a binocularity. So I believe what I notice when a patient has a good binocularity, whatever you do, surgery or Botox, just bring the eyes almost to orthotropia, and the patient will have excellent outcome. And that's what happens with intermittent exotropia. We just want to bring the eye near to ortho, and the brain will do the rest for us. This is one thing. Regarding the dose, when we say small dose, most of the time small doses are given for small numbers of strabismus, and that was proven in other, like I will present it later, that having a small angle of deviation, we will have better surgical outcomes. So when we have larger angles of deviation, usually the outcomes is poorer. And I think that will apply in both Botox and surgery.
Thank you, Dr. Abdullah. Thank you all for attending, and thank you, Dr. Shada, Dr. Amal, for this great interactive session.
Good morning again, everyone. And I would like to thank all of the previous speakers for their enriched introduction to botulinum toxin, which will be able us to move to the heated debate and a more interactive session. Our session will be botulinum toxin versus surgery, an evidence-based topic debate and discussion, and hopefully it will be a very heated and more interactive session. I will give you a brief introduction to our next session. It's a debate, and it will include 4 topics, debating Botox, the effectiveness of Botox versus surgery. The topics will include the first one, infantile esotropia, partially accommodative esotropia. The third is special neurological disease. And the fourth is residual esotropia after surgery. After each debate will be given by 2 speakers. One will be in favor of botulinum toxin, and the other one will be in favor of surgery. Following that, we'll have a poll, and then a small brief discussion, and then we'll repeat the poll again to see if there is any change in consensus regarding the poll in botulinum versus surgical intervention. Our first debate will be infantile esotropia, Botox versus surgery. Our first speaker will be the father of botulinum toxin in Saudi Arabia, and proudly to call my mentor, Dr. Saleh Al-Misfer. He is a pediatric ophthalmologist and the chief medical officer at KKesh. And also our other speaker who will be in favor of surgery will be Dr. Gorka Sesma, chief pediatric ophthalmology and strabismus division at KKesh. So we'll have Dr. Saleh Al-Misfer first, and then Dr. Sesma.
Yeah. يلا افتحيها عشان. We'll start with the question as mentioned by Shada. Okay, what is the preferred procedure to correct an infantility in 4 years old with 70 prism diopter? Botulinum toxin, incisional surgery, augmented surgery, surgery plus Botox, muscle surgery, 3 muscle surgery, others. This is the second question. What is your preferred procedure to correct an infantile ET 6-month-old with ET35? Botulinum toxin, incisional surgery, and others. Seem to be that Botox is winning against the incisional surgery, and we have only 2 questions or more. Okay. How could I reach my presentation, Yanshada? Okay. I didn't know how could we manage strabismus cases if we didn't have Botox. In reality, I look at Botox as one of the magic tools to help us to guide this patient to achieve a good outcome. And in surgery, if you do a lot of surgery, once you start to see complication, you will think about Botox deeply and thoroughly. I didn't know where is my presentation. Who will put it? I should put it or they will put it? Okay. This is the pointer or no? Yeah, okay. طيب. Okay. Like to go back one slide. خلاص. Okay. If we go back to history, after our training at King Khaled Specialist Hospital, Dr. Keithingle joined us. And at that time, the Botox was just approved by FDA in North America. And he's the first one, I could say, that he introduced the botulinum to King Khaled Specialist Hospital. At the beginning, we are just doing such a procedure for adult patients. And we have the EMG, we have Teflon-coated long needle. It was, very painful, difficult. We have to take the patient to the MTR, minor trauma room. And I found that it is really start to not to book patients through that area because it is really, it's not as straightforward. And I decided to move the patient to the OR. In the OR, I could include pediatric and adult. I could be more control, and we decided not to use any Teflon-coated needle, and we started to use 30-gauge needle in TB syringe, which is more easy. And I think we are maybe the one who did the procedure with TB syringe early, but we didn't publish this in any journals. Is there anti-Botox in case of you have risk or afraid that the Botox may cause poisoning to the patient? At the beginning, and there is 2 types of anti-Botox. There's something done in horses, what they call equine, and hepativalent, which is done in human. And this antidote is just used for botulinum poisoning in pediatric age under control. Is there the lethal dose? At the beginning of the history of the botulinum, there were cases given high doses and they ended in the ICU, where they kept in the ICU for weeks to recover. And they identified that the lethal dose, this has happened to one nurse in Germany. She got botulinum for cosmesis and she ended in the ICU. And the lethal dose is about 35 to 40 units per kg. Does botulinum neurotoxin help cause infantile ejectio to change to a more manageable form? This is one of the meta-analysis study published in the investigative ophthalmology and visual science under the ARVO umbrella. And it's very good study for those who would like to have more view about botulinum. This is very good article to be reviewed by you. If you like to have it, it is just go on the online and it's a free article. In this study, they include 9 studies eligible for inclusion. The group success rate of botulinum neurotoxin treated in infantile was about 76%. The confidence interval is about it's ranging between 61 to 89. The complication encountered in this study, the exotropia is 1%, ptosis seen 25%, vertical deviation 12%, and the mean changes in deviation was minus 30.7 prism. We'll not go through the theory, the mechanism, why we have patients with infantile esotropia, because it is all of you came across this. The binocular outcome can be very poor, in spite of all the trial of correcting patients with infantile esotropia, either with botulinum or the surgery. No way to restore binocularity, but intervention between 3 to 6 months is very fruitful, and you may obtain a good stereo acuity. And this in this study, they did some cases at this age where they ended with 40 seconds of stereo acuity. Infantile esotropia, finding it is usually normal CNS. Start between, sometimes you see patient at 2 months with infantile esotropia, but between 3 to 6 months, this is maybe the good timing to inject patient with botulinum. I prefer, if I have patient with infantile esotropia at this age, to give him botulinum. But the problem, most of these patients, they will not come to your clinic as early as you expect. Spontaneous resolution to orthophoria is unlikely to happen in a patient with infantile esotropia. Since there is no fusion, the latent nystagmus, inferior oblique overaction, and dissociated vertical deviation are secondary to lack of a fusion. Patients with a fusion, rarely they will end it with latent nystagmus. Rarely they will end it with DVD or inferior oblique overaction as a secondary to lack of a fusion. I noticed that those patients who lose vision early in one eye, they may end it with latent nystagmus and abnormal head position to dampen the nystagmus to improve the vision. And this is happening with our patient who ended with enucleation. For this reason, this has been published in the literature, and if you go through the browsing, you will find such finding. Why surgery is not my favorite at the beginning. First, what is my aim to do with patient with infantile esotropia or any type of strabismus? We need a good alignment. We need good vision. We need good binocularity. For me, the success rate, if I obtain and retain the binocularity. Patient under-corrected by 6 to 8 prism, over-corrected by 6 to 8 prism, this is just success in alignment, but it's not success in fusionability. I look at the patient to 2 groups. Fusionability patient and non-fusionability patient. Those one with the fusion, I work hard to regain the fusionability, because by this way I could maintain their alignment forever. Those patients without any form of a fusion, it is just a cosmetic and alignment to improve the patient, how he looks like in front of others, and to give him more self-confidence. Surgery, you need at least 24 to 30 instruments. You need appropriate orthoptic workup, which is, I think it's impossible in young patient, and the orthoptist, Lena, she is struggle with this patient to obtain a good appropriate measurement. For this reason, Dr. Saif, he said, go with lowest estimation to avoid overcorrection. Surgical time is there. You need a surgery under GA. You cannot do it for patient with infantile esotropia at young age without putting patient to the surgery. Surgical rate is in the range of 1.7 to 3.5. You have to redo it again and again, and second deviation like inferior oblique or DVD or others. Overcorrection is a matter of concern, because these patients in young age, their medial rectus muscle is very thin. And if you manipulate it with vigorous power, you may cut it easily. And it could be torn easily, very easily. Preoperation rate is common and consecutive, according to the von Norden. If you go through any von Norden publication, you will find that the consecutive exotropia after bilateral medial rectus recession not less than 70% in 10 years, not after a few months or a few. In 10 years, you will find these patients ended with elongated scar, slipped muscle. It's not lost, but slipped muscle, and you will need to do it again. Surgical complication is very common in certain hands and very low in certain hand or seldom in certain hand. For this reason, the complication rate is dependent on the individual. I could say to individualize the skill. You may have patient with globe perforation, retinal detachment, cellulitis, endophthalmitis, hemorrhage, intersegment ischemia like this slide. And there is a big, well, you will find a lot of books and textbooks just entitled strabismus surgery complication, which is you will not find anything about Botox. Conjunctival cyst, pyogenic cranioma, and disruption of the normal tendon insertion. The normal tendon is inserted to the sclera and incorporated with the sclera fibers. Once you disinsert it, especially for the medial rectus muscle, which has easy to retract more, you will not be able to create a normal tendon at the sclera at any location. It is just artificial mechanical fixation with a suture. For this reason, if you need to be sure that this muscle will not disinsert, use non-absorbable suture. Those patients with the large recession, I didn't recess more than 6 millimeter in medial rectus muscle, because I know once the muscles go beyond the physiological insertion, it will just be hanging on the sclera. And once the suture is resolved, there's a high chance for this muscle to, the scar will elongate. While in botulinum toxin, you need just the vial, a lidwar speculum, topical anesthesia, TB syringe with 30 gauge needle, and just a alcohol swab, and this is more than enough for you to conduct such a procedure. Comparable to strabismus surgery, we need surgical kit, scrub nurse, anesthesiologist who will stay with you for at least 1 hour, preparing the patient, anesthesia clearance, and a lot of things that will interfere with sort of procedure. Management challenging. Orthoptic is not that necessary to have an accurate orthoptist or skillful orthoptist. You could do it by yourself. You will say that it's AT. Mask anesthesia, procedure in the range of 3 to 6 minutes. Could be, done for any young age. There is no, but surgery, I will not do surgery for patient less than 5 years. This is my rule. I didn't do surgery for any patient less than 5 years. Undercorrection is unlikely. Overcorrection is strongly indicated. Why we need more action? Once patients become divergent, this will stimulate diplopia. Diplopia is very important for us. What we're maintaining our eyes is diplopia avoiding mechanism, which is the fusion. Once you have the fusion, it is the mechanism that will prevent diplopia. If you don't have a fusion, you will be diplopic. The eyes will go in different cases. For this reason, I think diplopia is indicated to stimulate fusion in those patients who has a fusion ability. If they didn't have fusion ability, even if you create diplopia, it will not work. Re-injection is very common. Consecutive extropia is very rare. I have patient ended with a consecutive where I have to go and do lateral rectus recession, but those patients usually they are very young and you give high doses for a small deviation. There is one important point with the surgical technique in botulinum, how to avoid globe perforation or retinal detachment. This is rare. I didn't know if anyone of you encounter perforation of a sclera with botulinum, but we encounter cases at KKish with the trainee. And the Botox was injected inside the eye where the pupil become dilated for a while. It is not responsive, and retinal detachment, we didn't encounter any cases. Endophthalmitis, I can't recall any case of endophthalmitis. I saw cases of endophthalmitis after surgical intervention and perforation of the sclera. Hemorrhage is common, with any type of procedure, but it's very rare even with cellulitis. Like big cellulitis is unlikely, lost muscle is unlikely, cyst, pyogenic, disruption of the tendon, all these will not happen. how could you look at, when you look at the slide of the needles shaft, the needle bevel, if you use the same needle to draw the botulinum from the vial, it will lose its sharpness. For this reason, it's preferable to use a 25 gauge needle to draw the botulinum and replace it with 30 gauge needle. The 32 gauge needle, which is available for a diabetic patient, is very short. For this reason, I prefer to go with 30 gauge needle. This is the success rate as according to that meta-analysis study, which is published by one of the ARVO journals. I strongly believe in botulinum for the young patient who are less than 5 years against surgery. And the reason I didn't like to see complication. I saw cases of complication, I mean, all the way from just small conjunctival cyst to orbital-like cellulitis to lost muscle. I mean, it is, I mean, very, very unhappy situation to see patient with complication after strabismus. I saw patient where they lost the vision. Binocular vision could be, according to this study, this with bagulin striated glasses was detected in 86 of the reliable responders after botulinum and 78 after surgery. For this reason, if you catch the patient as early within the 6 to 9 months or less, there is a chances to regain fusion. After that age, I didn't think you could regain fusion at all in infantile azootropia. Gross stereopsis was demonstrable in 10 of 15 patients in botulinum group and 9 out of 13 in surgical group. 2 patients ended with stereoacuity of 40 seconds. Botulinum toxin injection to the medial recti muscle revealed to be a very safe procedure and offer a valuable alternative to strabismus surgery in congenital azootropia, especially in moderate deviation, and it will minimize the surgical volume in large deviation. I prefer to use botulinum for infantile azootropia who are less than 5 years. I will not do surgery at all. Even if they have 60, 70, I will wait till they are grow up and will do surgery. Thank you very much. Dr. Gorka Sisma is going to debate with me and we'll see who will win.
Thank you, Dr. Masfar. Dr. Sesma, you ready? Let's see who will prove his argument more.
It's working. Can you hear me? No? No, yes. Thank you very much. Tough job, no? Well, if you don't see me tomorrow, it's that I'm in another country. So you put me the presentation in the presentation mode? This is for, and the point, and pointer. Well, where is it? Okay, this is the pointer. Okay, thank you very much. Tough job. Huh? Well, again, if you don't see me tomorrow, can you hire me in any hospital here in the... just to summarize this, you can watch. Huh? It's a difficult job, no? Start again, so have all the audience against me, but it's okay. I'll try to do my best. My experience, my real experience regarding botulinum toxin is wonderful. Okay. Today, when Sheda and the organizing committee invite me, well, I feel really grateful because it's a very interesting situation. No? I was trained as a surgeon, and my first experience was about botulinum toxin was here. I learned botulinum toxin 15 years ago, but the real one I learned from Dr. Mesfer, Dr. Awad, Dr. Chamrani. They taught me everything about the Botox. And I changed my mind. I use Botox. However, we need to talk about the evidences. And you remember all the things that when we were studying epidemiology and the level of evidence. So I need to try to defend myself using scientific evidence. The first history about this one start with that couple of papers, very nice papers in 1997. These papers, the first one is from McNeil that was mentioned in many of these lectures before, and the reply that Dr. Burton Kushner did it. What is the story? You have the QR codes in case that you want to grab these nice papers. The paper of McNeil was in 1997, no? And probably after Alan Scott started using Botox, probably this was one of the first more cited papers regarding about, it's like when you discover an antibiotic and this antibiotic is the solution for everything. Well, in 1997, all the people was in the Botox for everything. And he wrote this paper, very nice paper. The paper was comparing the use of Botox, for example, for infantile esotropia. Look at the doses that were they using, no? Minimal doses. Americans usually they use 2.5, 3 doses. When you mention to the Americans that we are using 10 units, 8 units, they get crazy. What are you doing? But and they were doing in bilateral mirror rectus. And also, look at this very interesting part here, no? They were using in infantile esotropia, and the previous preoperative angle was 33% diopters in average. So they did it, and they got this result. 89% of success after Botox. That was so the people say, wow. Well, Dr. Kushner reviewed critically this paper, and he starts saying, well, listen, when we analyze carefully this paper, there are a lot of limitations. For example, the follow-up of this patient. Dr. Shamrani was mentioning something that was interesting. Many of the papers that you check in the literature, the follow-up is 6 months, 8 months, 1 year. And we don't have chance to see the changes induced in the muscle. So Kushner, that is not me, Kushner is an important guy. He mentioned the 4D, the correct follow-up of the patient. Then he also mentioned that, is this the panacea to treat all these patients? Also, the way that in this paper, the way that we're treating the patients, basically inclusion criteria. It's supposed that in this paper they were mixing patients with infantile esotropia, with partial accommodated esotropia, older patients with younger patients, different angles of deviation with older, and basically they were including, for example, patients with 25, 30% diopters, which is pretty rare in patients with infantile esotropia. Dr. von Orden says that, you need to have doubts about a patient with 30% diopters that this is an infantile esotropia, probably not. So Kushner raised this issue that despite the fact that we have a lot of good success rates with the Botox, he criticized and he mentioned all these things. Lack of standard, follow-up, criteria. When we check all the papers about Botox, we can see that many of our papers, including the papers that we wrote here, are plenty of this one. Okay? So this is an issue. What is the evidence? Well, the first is this one, a randomized clinical trial where they want to compare Botox versus surgery in large angle esotropia. They include these patients. They include 1, 2, 3 injections and compare with patients with angle with less than 60% diopters. And they measure complete response. They call complete response less than 10% diopters of esotropia. Well, look at the results. Surgical group, 70%. Botox, can you tell me for me, please? 37. When they compare the population when they were older than 24 months, can you tell me how much was surgery? 79%. What about Botox? 16%. And when the angle was higher than 60% diopters, please, can you tell me the number? 79%. What about Botox? 25%. randomized clinical trial, high level of evidence. So in this case, this is one of the results. When we do regression analysis, multivariate regression analysis, we notice that the surgery was significantly, especially when the patients were older than 24 months, and the angle of deviation was higher of 60 prism diopters. Okay? You have here the results. So, surgery remains the gold standard for treatment of the infantile esotropia, especially in those cases. More evidence was presented this paper before. So we compare botulinum versus medial rectus recession. And this is a meta-analysis. BMR achieved higher overall success rate compared with the Botox. Botox procedure had higher overall rate of undercorrection. Significant. 2.27 folds compared with the surgery. This is just for you guys. There were no difference between the, the two groups in the case of overcorrection. BMR was more effective than infantile esotropia compared to botulinum toxin. Other meta-analysis, and that was mentioned by Dr. Esper. And it's the way that we can see the papers. He was saying in that paper, Botox was good, what Botox was, and it's true, it's true. However, we could see life like the glass of water, half full, half empty. He saw it half full, I saw it half empty. And you see, you remember this table that he showed us? Let's say Botox is a good outcome compared with the surgery. These are the outcomes. Look at this one. When you see, we see this table, you see 50%, that 5 down there means 50%. So you could say, well, Botox has a higher rates above of 50%, like you can see here, no? But look at the papers. Look at how many papers are, everything that is in the left didn't work. Everything in the right, oh, sorry. Everything in the left didn't work. Everything in the right worked. Everything that touched the line is not significant. So when we check this paper carefully, we can see that just this paper, that is the Magnier paper, the first one that I remember I told you, was significant. Oh, sorry, Magnier. But look at the outcomes. Means 1.0, means 100% of success. Can you imagine a result in a scientific paper like this? I never had this one. What happened in the Magnier paper? He had problems with the selection bias. He chose patients in a wide range of ages, and the criteria for the diagnosis was not clear. So now you believe me? Other meta-analysis. Let me go. When we analyze this one, the success rate is this one, and the injection, when you use it, we need to use it at least 1.6 times. Okay? When the deviation is smaller than 30 prism diopters, okay, they are equal. I agree with that. Surgery, 72% of success. More evidence. This is a systematic review. It's supposed that it's the highest level of evidence, no? You have the QR code. You can get it if you want to read it, if you don't believe me. And in this systematic review, they compare botulinum versus other options, and including in these options, the infantile esotropia. They review 2 trials where they compare this one, but the main conclusion of this systematic review is that all the data has low certainty evidence level. Similar or reduced Botox versus surgery, sensory fusion, less or equal, stereopsis, less or equal when we compare with surgery. When we check this systematic review, you can see something that is the point that Kushner raised. There is a lot of bias, and we as researchers and clinicians sometimes we don't pay attention to this issue. And according to the bias that if we don't pay attention to this bias, we could have outcomes, and we could move the p value to the right or to the left according to our needs. So we could be doing p hacking. Let's suppose that we don't solve the problem of the bias that is shown in this study. We cannot establish real conclusions. And we need to do randomized clinical trials. It's the only way to prove which procedure is better for infantile esotropia in this case, or other pathologies that we discussed this morning here. So this paper show low certain evidence. If we organize something better, we could do better, higher evidence. Now I'm finishing, but beyond the scientific evidence, there are two aspects that I would like to comment. First is the economical aspect. Sometimes we have difficulties, probably not here in Saudi Arabia, but in the world. Getting access to the OR is difficult, and sometimes we need to work like a sniper, one shot to try to solve as much problem as we can. And in these cases, surgery could be an option because we have higher rates of good outcomes. But it's another aspect, and it's published here. This paper is a paper for Michael Wan and David Hunter in Harvard Medical School. They published this paper, and they mention in the paper something that is very interesting. That the decision to do Botox or surgery depends on the surgeon, like they say, Americans say, no? But look at this one. You receive $800 if you do Botox, but if you do surgery, you receive $2,783 Scientific evidence or commercial interest? We can cover many things, and we can discuss. I'm not saying that we are doing this one. You were discussing in the morning, we were discussing about the ethical approach to our career, and this could be a factor. I'm not saying, and we can justify with science this factor that could be hiding there. So in summary, I consider if the patient has more than 60% diopters, we can do surgery. If it's older than 2 years, we can consider surgery. If we have difficulties for multiple procedures, we can consider surgery, but every time the case should be tailored, okay? It's tailored. You tailor the case and you decide. And as a proposal, let me tell you something. The people who apply Botox in the world is seated here. The institutions who apply Botox in the world are seated here. We are experienced people in Botox. And my proposal is that why not we do a randomized clinical trial? We have the facilities, we have the resources, we do Botox, we do surgery, and if we do it multi-center, the scientific evidence could be higher. And I suggest, in the case of infantile esotropia, these criteria. But at the end of this meeting, I'll be outside, I'll be around, someone who is interested to join me, because it's not join me, it's group. We can call this one strap bot or bot strap or whatever we can call it, but I'm sure that we can develop. And to answer the question of Dr. Kushner, using the 4 dimension, that is follow up these patients for long term in the proposal of a randomized clinical trial. Thank you very much.
Thank you both. We're going to have a poll question now and see if there is any change of hearts after this argument.
I had a job in Kekesh.
50-50.
Okay, guys, has been a pleasure to meet in Saudi Arabia. Where are my fellows?
So still botulinum toxin. So for this one, botulinum toxin. Let's see the other question.
It's a
40-70 prism diopter. 50-50. Augmented surgery plus Botox. Good. So still Botox has a role. Okay, we'll proceed to our next argument, which is Botox versus surgery in partially accommodative esotropia. It will be presented by Dr. Shada Al-Frehi and Dr. Abdullah Khan, Associate Consultant of Pediatric Ophthalmology and Strabismus and Adjunct Assistant Professor, College of Medicine at Al Faisal University. Dr. Abdullah.
Thank you, Dr. Shahir. First, I would like to thank the organizing committee and Dr. Shad Al-Farehi for really putting this meeting together. We can see that Botox, at least I'm happy that the Botox is working for infantile esotropia. So let's see Botox in partially accommodative esotropia. I will be in favor of Botox. So let's see first, sorry. Okay, let's answer this question. Typical scenario of partially accommodative esotropia, what you will do, Botox or surgery? Now 50-50, Botox is, okay, Botox is winning. That makes me relax. Okay, so also I would like to thank all the attendees here today and also the attendee in the Zoom. We have 128 participants actively now. So thank you all for attending. We can see Botox is winning. So let's see why Botox is winning. Okay, so what I will talk in my presentation that what is the success rate of partially accommodative esotropia using Botox? Is it one or more than one Botox? Is it the dose? Is it really safe? And factors for success. And lastly, high ACA ratio using Botox. And this clicker, I think, needs more time to. Okay, then lately, why not surgery? I will start with the Alan Scott. In his study, you can see here the final success rate for partially accommodative esotropia was 71%. And those patients, what is the duration of follow-up? It was ranging like the average 28 months. And also, some of those patients had prior surgery. So there were some prior surgery for those patients to achieve this success rate. He quoted very important note. He said, it is interesting that the alignment result for secondary injections were better than primary injection. But this was not only for primary partial accommodative esotropia, for all the group, ET with XT, he reported more injection is, you can find more success. Then in this study, after single injection, what is the success rate of Botox? It was 59%. Another study, which was, this is the Kekesh experience about Botox for partial accommodative esotropia and infantile esotropia. 260 patients, partial accommodative esotropia. The success rate was 53%. This is after more than one injection. And studies with this, they reported in this study and also other studies, patients who have a smaller angle, they have more success rate. So in this study, they have more than one injection, and you can see people who are asking, well, if I use first injection is not favorable. You can see here, first injection, 53 success rate. Second injection, so from 109, the second injection, still you have people who are succeeding. People who underwent third injection, still you have people who are succeeding. So with each time you give injection, you anticipate that you will have an effect or success rate. Let's see this table. If you have all of those variables, what do you think is good variable or the variable that will affect the outcome? Is it the age? Is it the gender? Is it systemic association, amblyopia? So they found three things. Deviation at primary procedure, less is more successful. They found overcorrection after 1 week. This is what we talked earlier. If you saw the XT post Botox, you know that the effect will, the success will be higher, and patients with partially accommodative esotropia, they were more likely to succeed. This is actually the summary, and also regarding the dose, when they compared all the doses, there was no significant difference regarding success. And as we know, there is till now no clinical trial answered this question. What are the complications? Because this is one of the largest study to study Botox. They found 5.7% developed persistent consecutive exotropia. But is this consecutive exotropia for infantile or partially accommodative? It's not published in the article, and this is one of the limitations of major articles you can see in this topic. They combine both infantile and partially accommodative as esotropia, and they put the conclusion at once. I prefer if they can separate the conclusions. And also in the literature, what is recorded is 1 to 5% you have consecutive exotropia. And majority of patients, they have ptosis, but none persisted. So we can say it is this is regarding safety. Dr. Fatma, she already mentioned this in her presentation. What I want to show again, that you can see this table, see the success rate initially. It was 47%. After the second dose, it increased to 62%. After the third dose, it is 65%. And this is again for both infantile and partially accommodative. What about partially accommodative alone? Okay. When they compare it to BMR surgery, they found Botox is more, the success rate is higher. And it is statistically a significant difference. The question why? Why we have the surgery here is less? Usually it is the surgery is higher. It's about the duration of follow-up. If you have more follow-up, you can have more, the success rate of surgery will decrease. And they reported also a patient, if you have a patient with Botox, there are 3 times are more likely to have successful outcome than PMR. I can see Dr. Shada Al-Farehi, she's looking at she will say the opposite to what I'm saying. So what about residual esotropia? They were not different between the two groups. Consecutive XT, you can see it is there about 11%. And it is 11%, and this percentage will go higher. But just give the patient more time, they will drift out. Okay, another study, you can see the success rate in this study was 70%. Does it work in high ASA ratio, Botox? There is nice study, they compared two arms, Botox versus BMR with Foster suture. They used 2.5 unit to 3 and BMR, and the percentage of success rate. Both were successful, but you can see that Botox has higher success rate, 93%. Also, Botox has significantly better stereo acuity than surgical group. And the mean distance of deviation was still better in Botox group. And you can see, is there a difference in the baseline characteristics? There was no difference except for refraction, which is almost like similar. You can see the average of refraction. I will not spend more time here, but you can see the success rate. Although both groups, here I'm not saying surgery is bad, but I'm saying both achieved good outcome. You can see the near deviation in prism diopters, both like the range less than 14, but surgery, Botox was higher. Okay, this topic, I think Dr. Shada, she will emphasize on it, so I brought it here. This study was done by Dr. Shada and her group to specifically answer our question, Botox or surgery. And you can see she had large number of patients, and also the success rate here is 53%, and the surgery is 70%. Everyone will think that surgery is the good, but let's see two things. Mean duration of Botox, you are talking about 5 minutes. The surgery, you are talking about 70 minutes. Okay, this is one factor. And the mean follow-up, 31 months in Botox, while in surgery is only 16 months. So if this 16 months became longer, I believe this 70% will not be 70 anymore. Lastly, persistent ptosis was seen only in one patient, while consecutive exotropia in this study was seen, sorry, it's not showing the slide, it was shown 2%. So here again, what do we have in the literature regarding consecutive XT? So this study, they found the long-term outcome of surgery, they have about 44% developed XT. Dr. Mesfer, what he mentioned that 10 years, it can reach to 70. So if you want to do the surgery twice, do BMR. And so by this, I will end my slide. Let's see one by one. Botox, super quick. Surgery, it is long. The cost, it is less for Botox. It's more for surgery. Anesthesia, super quick. Mask anesthesia, the other one needs general anesthesia. Scarring, you don't have any scar on Botox, while in the BMR you have adhesions and scars. The success is high in Botox, but you can do it more than one. Don't expect high with only one injection. Number of operation is short procedure, but it can reach to up to 3 injections in Botox, while BMR, you will do first BMR, then you can deal with the consecutive later on. Consecutive transit and the BMR, it is more, and the complications, I think most of you are aware of the complications of the surgery. So let's go, okay. We can repeat the whole question or at the end? Okay, at the end we will do it. Okay, thank you.
On. Okay. And let's see if Dr. Shada can beat that with her argument. Shada.
I'll take the challenge. Thank you very much. Can I have my slides up? I'm actually prepared to fight back and stand for surgery for partially accommodative esotropia. If I can have my slides up, please. I'll tell you why I think surgery has the upper hand in partially accommodative esotropia. I hope I can convince you by the end of my talk. Okay. Okay, so which one, Botox or surgery? I'm a fan of Star Wars, so let's take up the war and see which one will win at the end. So surgery is performed to correct the non-accommodative component of the deviation measured through the full hyperopic correction and partially accommodative esotropia. So the goals in surgery in this disease in particular is to straighten the eyes, achieve binocularity, which is achievable as these patients develop esotropia at later age. It's unlike infantile esotropia. Partially accommodative esotropia usually occurs at a later age. An older patient where binocularity is achievable and retainable. So this is one of the things that I look at in my goals for surgery. And plus, it has a low complications rate. I know they have listed all the rarest complication to try to drive it away from performing surgery for these patients, but I will speak against that. And I will show some of the complications of Botox as well. They argue with cost, and I think that the overall cumulative cost of re-injecting and readmission a patient, as mentioned by one of the papers, it costs about $700 to $800 for each Botox injection and $2,000 to do one surgery. And I think they balance things out, and I don't think that's cheaper at all. So why perform surgery and not Botox for partially accommodative esotropia? Well, as I mentioned, esotropia at this age esotropia in this entity in particular develops at an older age. Binocularity is achievable. Accurate measurements are possible. So they're older patients, and you can actually get accurate numbers, and you can measure it through their glasses with multiple visits. Over or under corrections can be also adjusted with the glasses. You can increase their hyperopic correction or decrease it if you have an overcorrection after surgery. So you have room to work with as well. You can address ACA ratio, as mentioned by Dr. Khan, by adding a Faden suture to the medial rectus as you perform surgery, and that wouldn't be achievable with just Botox. Consecutive exotropia in this entity in particular is very low. We're not talking about the infantile esotropia type where they don't have binocularity. I think the binocularity is the cause of consecutive exotropia, whether you go for Botox or for surgery. Infantile esotropia, in contrast to partially accommodative esotropia, these patients are binocular. They had binocularity. They're not, you cannot compare infantile esotropia to partially accommodative esotropia. Okay. So consecutive XT will happen in infantile esotropia whether you go for any modality of treatment. But in partially accommodative esotropia, it's quite low. Okay. So you'll tell me where is the evidence? Where is the data? And I'll give it to you. First of all, Dr. Khan mentioned this paper. We had that question in particular. Should we do surgery or should we do Botox for these patients? I just returned back from my training, and I was considering using Botox, and I had this question in mind. So we looked at all of our data at National Guards, where we looked at all of our patients over a 10-year period. We designed this retrospective study. We had 224 patients, and we tried to, this was a retrospective study, so I did not choose to follow up patients less in the surgery group, but that was what was there in our data. We intended to follow them to look at the final postoperative angle at the last available visit. So let's look at this paper in detail. So we had 224 patients. As you can see, 103 had surgery and 121 had Botox. This can tell you even before starting, that our surgeons at our group, we're multiple surgeon, prefer Botox for this entity, okay? So there were more Botox for surgery. However, if you see there, for the first Botox injection, unlike the paper by Dr. Fatma, we only had 52%, we had, 41% success rate, and 52 failed the first Botox injection. So we were talking about like 50-50 success rate, almost comme ci comme ça, if you say it in French. So it wasn't like the 70 that they had. With repeated injections, we expected to have increase in the success rate. However, with the last follow-up there in the one patient received 5 Botox injection and the cumulative success. So when you look at success rate, you have to look at the cumulative success. You cannot look at the success rate of each individual Botox injection. So you have to look at the whole patients as a patient and look at the cumulative success and not the success. You don't add the success at each and every Botox injection. That would increase or inflate your success rate. Okay, so that's what we did. We calculated cumulative success. And with the cumulative success, we were not able to reach more than 53% of success rate for Botox. And a lot of patients also, 20% of the patients who were in the Botox received surgery after their first injection. So we didn't have many patients in repeat injections, but even with that information, 50% only were successful. On the other hand, in the BMR, most of our patients had 1 surgery and the success rate was 73. And we had a good long follow-up. I mean, 14 months is not a short follow-up period. It's a good amount of follow-up. And only 30% failed, which is normal. This is the normal success rate in the literature for any strabismus surgery, which is comparable to our results here. And only 3% of them were reoperated. So let's look at the postoperative observations, the exotropia that they're talking about, and all the different complications that we looked at. So if you see Botox there is in blue and the BMR is in orange, you can see for all of the variables, Botox had more complications, namely vertical deviations, more DVD, more significant postoperative inferior oblique overaction. Botox disperses in the orbit. You give it to you intend to give it to the media rectus, but it disperses. It goes everywhere. So you have more vertical deviation and you have more inferior oblique overaction. And that was clinically significant. The difference is huge between the two. Okay, so it's, on the other hand, consecutive XT was only 2%. Right there. Almost nothing. That was the complication of surgery. That's it. So to summarize, the overall success rate was significantly higher in BMR group versus Botox, 53%. And despite the larger number of patients with small angles, we looked at different responses from different angles, preoperative angles. Even the smallest angle did better with surgery, significantly better with surgery. Okay. 80% success with BMR versus 61 with Botox for the small angle. So Botox is significantly shorter duration. Yes, it might take you 1 or 3 minutes, but on the long run, you'll have to bring the patients for multiple injections and you don't reach the success rate of surgery. Complications rate is also higher in Botox, as I showed, specifically in inferior oblique overaction. We didn't have sensory outcomes, which is a limitation to our study that I have to declare. So let's look at the papers that Dr. Khan showed you. And this was a paper from KKISH as well. And there you go. There's their success rate, 50%. It does not reach more than that. And we know from many studies in the literature that the success rate of operating on patients with partially accommodative esotropia is higher than that. Okay, these are the papers that I'm mentioning. Motor success rate after surgery for partially accommodative esotropia. The only paper that shows a low success rate with surgery is the paper that Dr. Khan presented there, Arnoldi, the second one here on the table. 37%, and it was the follow-up was 2 years, and their definition of success was 8 prism diopter of orthotropia. On the other hand, if you compare it to other studies, look at the paper by Kushner. He had 5 years of follow-up, and he had 91% success rate. Mohan there from India followed the patients for 10 years, and he had 50%, but he showed the success rate in different timeline after surgery, and it decreases with time, yes, but at the end, at the 10-year period, 50%. Qasim and Al-Hilali, I think this paper is from Egypt. They had 85% with 6 months of follow-up, which is expected. So this, the shorter follow-up, the higher the success rate. Okay, so motor success is achievable in this patient and achievable with surgery. Okay, this paper, which I just mentioned, Mohan, showed the sensory outcomes of surgery. And let's look at the sensory outcomes for surgery in particular. This is a table for sensory outcome. So sensory outcome in partially accommodative ET, as I mentioned, is achievable. And there is the data. Many studies in the literature showed binocularity and stereopsis regaining them in those group of patients. So again, to summarize, to recapitulate, pros of surgery, it's effective. Published surgery success rates are higher than Botox for partially accommodative esotropia. It's scientifically based, supported by retrospective clinical trials. They have, you can also target high ACA ratio, can be addressed by surgery. You can easily adjust surgery. You can titrate the glasses. Low complications rate, lower than Botox. I know Botox might take you 1 or 2, 3 minutes, but the complications are higher. And it's low cost. It's actually as the same cost if you calculate the whole admission times. So in life, there's a shortcut, but there's a right way. Okay? So for me, surgery is best for partially accommodative esotropia.
Thank you, Dr. Shada. Powerful debate between Dr. Shada and Dr. Khan. And let's see if this will be reflected on the poll again.
All right. Remember.
Remember.
Remember what's best.
Botox, surgery, Khan, Shada. Still, let's see. You can't vote. You can't, the panel cannot vote. Wow. 50-50.
Don't change your mind.
Okay.
One more vote, then we're closing. Please, BBMR.
Botox is winning, I think.
Botox is winning, but not as before. It was almost 70% when we started the discussion or the debate, and now it's 52 versus 48. So probably some people had changed their minds.
Great. Glad to hear that.
Yeah. Okay. We'll move on to our next debate, which is the debate of Botox versus surgery in special neurological disease. It will be between Dr. Ahmed Abdelal for Botox. He's a pediatric ophthalmologist and strabismologist, ex-Prince Sultan Military Medical City, Riyadh. And between Dr. Taghreed Al-Najjar for surgery. She's a pediatric ophthalmology fellow, King Abdullah specialist, Children's Hospital, and Ministry of National Guard Health Affairs, Riyadh. Let's start.
Thank you for the introduction. It's an honor and a pleasure to be speaking here today. I'm happy Botox is doing so well so far. Hopefully the trend continues. So the poll question is, do you prefer conventional strabismus surgery to manage ET in patients with cerebral palsy or Down syndrome? As opposed to Botox, of course. Okay, so the poll is closed. Seems like already people are preferring Botox. Yeah. Okay, so I'm going to be arguing for the use of Botox in special neurological conditions. An overview of my presentation. I'll be introducing the topics and some definitions I used in this presentation. I'll go over the epidemiology of strabismus and cerebral palsy since it's the most common disease discussed in the majority of the papers. I just want to touch on the surgical outcomes in these cases because they're notoriously associated with under and overcorrection. I'll give you some papers supporting Botox. There were so many, but for the sake of time, I'll include the three with the largest number of patients. And then I'll conclude the topic saying why Botox is better than surgery. So for the purpose of my presentation, I'll be using this abbreviation CPND, which is cerebral palsy and neurological disease, in place of the neurological conditions covered by all the papers. There were multiple studies included in this paper. There are no systematic reviews or meta-analyses, as you can imagine, because of the rarity or complexity of these diseases. Other than cerebral palsy, there were cases of hydrocephalus, mental retardation, prematurity, epilepsy, encephalomalacia, and other conditions. Cerebral palsy was by far the most common neurological condition in these papers. So it's just worth taking time to talk about it. It's the most common disability in children in the US. Strabismus is the most common ocular manifestation of cerebral palsy, and its estimated prevalence is 11 to 50%. The majority of the studies actually state the range is between 40 and 60%. This is why actually this debate, other than for deciding which is better, is these children we need to find what's the best source of treatment for these patients. Is it surgery? Is it Botox? One of the reasons why we should aim to treat these patients, of course, is the psychosocial implications of treatment, the cosmetic value for these children who deal with multiple disabilities. It's been shown that ocular alignment helps promote their self-acceptance. It's also beneficial to them and their parents in establishing connections, especially at earlier ages. Is this where the benefits stop? No, the benefits are also proven in terms of sensory outcomes and binocularity. So this is a paper, it's on surgery. It's one of the few surgery papers on surgery that I'll talk about, but it's important to talk about because it's the only one that looked at sensory outcomes. So Dr. Fatma Ghasia, she had 50 patients with cerebral palsy. She did standard dose surgery. Her definition of success was orthotropia within 8 prism diopters. This was achieved in 58%. What's important to look at is the fusion response. There is potential to restore fusion in these patients. So 50% for esotropia and 25% for exotropia in patients with neurological disease. It's less than those without neurological disease, but there is real reason to treat these patients early. Again, same thing for stereopsis, 20% in ET and XT. It's a bit less than for those without neurological conditions, but again, I just want to emphasize the need for early surgery. In these unhealthy children, maybe surgery might not be possible, which is why we'll argue again for the use of Botox. So classically or almost anecdotally, it's mentioned that surgery has high failure rates in cerebral palsy and neurological diseases. There are multiple papers. It's even mentioned in textbooks. The rates of overcorrection are between 6 and 21% in patients with cerebral palsy compared to 2 to 4% in neurologically intact children. For undercorrection, the literature or the range is between 38 and 42% in patients with cerebral palsy, compared to 4 to 6 in neurologically intact children. This has led to many people giving suggestions, and they suggest adjusting the nomograms. This is exactly what Dr. Abbott Wilner did. So this is a major article which was published in the Journal of American Academy of Pediatrics. It was only 24 patients, but they underwent BMR with an average reduction of the surgical dose of 0.75 millimeters. They followed up these patients for 5.3 years on average, and surgical success rate of one procedure in these children who most of the time have multiple comorbidities, and it's not straightforward to book them for surgery. The success rate was only 37.5%. So out of 24 patients, they had 15 failures. These 15 failures had undercorrection in 10 of them. Overcorrection was 5 of these patients. From the 15 failures, 8 of these patients agreed to undergo a second procedure. And considering the success rate of the first and second procedure, the success rate climbed from 37 to 63%. So their conclusion was the initial success of surgery is very low, and in children with developmental delay, satisfactory alignment is possible. However, you might require more than one surgery. Now I'll move on to the evidence supporting Botox injection in these patients. So I'll be presenting 3 papers. The first was published in the Journal of Strabismus. It's by Dr. Ahmed Amri. It's titled Clinical Outcomes of Botox in Patients with Cerebral Palsy and Esotropia. So this is a non-comparative prospective interventional case series. 44 patients, 36 patients received 1 injection, and 12 patients received 2 injections. The inclusion criteria for the 3 papers are almost identical, so I'll just present them now once. It's a neurological disease or cerebral palsy, non-accommodative, non-paralytic, excluded if there was positive force reduction testing or if there was any vertical component to the deviation. So in this paper, 44 patients, their mean age was almost 4 years. The mean angle of deviation is much higher than what we usually associate with Botox, given these children's conditions. It was around 52. The time of follow-up ranged in this study from 1 to 2 years. The definition of success in this paper was orthotropia or within 10% diopters of orthotropia after 1 year, and this was achieved after either 1 or 2 injections in 68% of the patients. With prolonged follow-up, as some of my colleagues discussed in their papers, this rate went down, and the success rate after the last follow-up was 61%, which is comparable to, if not higher than, 1 or 2 surgeries discussed by Dr. Habit in his cases of BMR. They did report a few cases of overcorrection with consecutive XT in 13% and residual ET in 25%. Their conclusion of this paper was that Botox is a reasonable, less invasive procedure. It's very important to emphasize here light anesthesia, face mask anesthesia in these patients who there was, for the sake of time, I couldn't include it, but there's a study on the risk of anesthesia in patients with cerebral palsy. So this is extremely important to consider in these patients. Furthermore, it allows for debulking. So if this child requires surgery in the future, you have less surgery to do. The next paper was published in the archive, the Brazilian Archives of Ophthalmology. It's titled Botox for the Treatment of Strabismus in Children with Neurological Impairment. It was a non-comparative, unfortunately retrospective interventional case series. It had a total of 50 patients, 34 with ET, the remainder with XT. They followed up these patients for an average of 1.5 years, or sorry, 15 months. The mean number of injections was 1.4. So this study, they had re-injections. How they decided who gets re-injected, if there was no reduction of angle, they were not offered re-injection and they were offered surgery instead. If someone responded and the angle decreased by more than 30%, they were considered for re-injection and then included in the study. Again, the mean deviation in the study is higher than what we usually associate with Botox. It was around 42. Successful motor alignment was defined as within 10 prism diopters of orthotropia, and this was again achieved in 60%. The statistical analysis of this paper showed that ET, as opposed to XT, smaller angles, shorter duration, meaning early treatment, was associated with higher success. Again, emphasizing in these children with cerebral palsy, maybe not fit for surgery, we can offer them an early intervention, give them higher chance of success. They concluded that Botox is a good alternative to conventional surgery, lower risk of overcorrection compared to the 20 or 30% mentioned in the studies regarding surgery. And the treatment outcome is better in ET than XT as we expect, and shorter duration of strabismus. The final study I'll be talking about was published in the Journal of Binocular Vision and Ocular Motility. It's titled Comparison of the Efficacy of Botox in the Treatment of ET in Children with Neurological Disease and or Prematurity. So this study had the largest number of participants. I just want to emphasize they included prematurity, including ROP, including the manifestations and the visual consequences of ROP. So this was a retrospective, non-randomized controlled study with 2 years of follow-up. It had 2 groups, the study group, which is those with cerebral palsy or neurological impairment or prematurity, were 56 children. And then they had the control group of healthy children with infantile esotropia. Again, their definition of success was orthotropia within 10 prism diopters after a single injection of Botox. The mean age of treatment was almost identical in both groups. The deviation was similar in both groups. This is the tables from the study. So the table on the top is the comparison pre-injection and throughout the study of the deviation. So pre-injection, we can see esotropia around 50, higher than what we usually associate with treating Botox. And at 1 year follow-up, the angle of deviation decreased to less than 10 in both groups, actually lower in the study group, but this is beyond the point of discussion. And then at 24 months, they're almost the same. No statistical significance. The further we go, there's no statistical significance between the two. If we look at the table in the bottom, which looks at the success rate, the overcorrection, and the undercorrection, the 3 columns to your left are the study group or those with cerebral palsy neurological disease. The 3 columns to your right are the children with confirmed infantile esotropia. We can see very similar success rates in both groups. At 12 months, they both have around 70% success with a single injection of Botox. At 2 years, there's a reduction compared to the two. It still wasn't found to be statistically significant, but this is where I tell you, keep in mind that they included patients who had ROP, which could have confounded these results. Still, looking into account, a single injection in these children achieving success in 50% is a good thing. You can offer another re-injection under light face mask anesthesia and hope for higher rates of success. This study concluded that the decreased angle of deviation and the absence of ROP were associated with higher rates of success. There was no difference between motor alignment in patients with neurological disease and prematurity compared to infantile ET. Botox injection can be used safely as an alternative to surgery. My take-home message for this presentation is children with cerebral palsy or neurological diseases warrant intervention for strabismus, whether that's with conventional surgery or Botox. There is not only motor alignment benefits to be gained, there's also the potential for improved sensory outcomes. As Dr. Sasma mentioned earlier, yes, Botox and surgery, we can have our own preferences, but it should be tailored really towards what the patient needs and what the patient has. Especially in these patients, it might be worthwhile taking into account what the pediatrician has to say, what the neurologist has to say, what the anesthetist has to say. The other thing is to include the parents in the decision-making and to expect substandard outcomes with either treatment modality. In conclusion, for my talk, looking at the literature, I could have included a lot more papers, but for the sake of time, I didn't. Botox is a viable option, undoubtedly with comparable success rates and lower costs and lower rates of overcorrection. The benefits include shorter procedure duration, it's repeatable, there's a potential ability to be performed at an earlier age, restoring binocularity in these patients. There's less risk of GA and its related complications, no scarring, no muscle positional changes, less patient and family anxiety. And in the future, if these patients do require, whether it's Botox or surgery, they need fewer surgeries with lesser doses. These are my references, and thank you for listening.
Today I'll present the surgical part for those patients with special neurological disease. It's not working. It's not working. Okay. In my presentation, I will concentrate on the 3 points: success rate, measurement of angle of the deviation, and operation type. At the end of my presentation, we'll give each point a mark so we can have a decision if the surgical options is better for this patient or not. I'm going to present 4 papers, 2 around cerebral palsy and 2 around Down syndrome. The first paper is this paper, surgical outcome of medial rectus recession in esotropia with cerebral palsy. In this paper, they compare the result of medial rectus recession with the cerebral palsy with a control group normal neurological patient. Both of them had medial rectus recession, but those with cerebral palsy group have 1 millimeter less medial rectus recession for each muscle, comparing with a normal population group. And they find the success rate as deviations within 10 prisms diopter in the last visit. And we can see in they involve 30 patients for cerebral palsy group and 60 patients for control group. And they have the end result of 60% success rate for the cerebral palsy patients comparing to 66.7 for control group with a mean follow-up of 3 years. For cerebral palsy patients, they have 9 patients had 2 surgery to get the success rate. And this is my second paper, also for the cerebral palsy. In this patient, all of the patients have cerebral palsy, but they compared the success rate between the patients who have a mild form of cerebral palsy or a severe form. The standard surgical dose table used for all patients. And the first surgery was BMR for the patients who has AT and XT for BLR for the patients who has XT. And the success rate was defined as the angle of the deviation less than 10 prisms diopter in the last visit. They involve 64 cerebral palsy patients, 82 with infantile esotropia. And the success rate for ET was 53%, with average of surgery 1.4. Out of these 28 patients, 12 patients of them had 2 surgery. And over correction occurred in about 5% in all patients, including those patients who have XT, in the mean follow-up of 6 years. So come out to my research that I did in 2022. This research is comparing the outcome of the success rate of surgery versus Botox in patients with Down syndrome specifically. So all the patients were Down syndrome who in the surgical arm they had standard surgical dose for BMR and the other arms was Botox group. In the mean follow-up 10.9 months, it's relatively short follow-up duration, but when you saw the result, it's come at 65% success rate in the surgical group and 30% in the Botox group, which was unexpected. I was suspect higher success rate in the Botox group, and this success rate for the surgical group come out from the first intervention. The last paper, it's a literature review where they are looking for the success rate comparing the surgical standard surgical dose or adjustable surgical dose for those patients. It's involved 11 article, and it come out that the those who had a standard surgical dose, they come out with success rate varying from 62 up to 58. With those patients who have adjustable surgical dose, the success rate varying from 38 up to 86. So this come out to the conclusion the published research does not support the giving reduced surgical dose in individuals with Down syndrome. So let's go back to our point. So for the success rate, we considered it's more than 50 for all the cerebral palsy patients, even if we use the standard surgical dose or we adjust it. And for the Down syndromes, they have also high success rate, almost above 60 from 1 or 2 intervention maximum. So this is, I will give for this point 2 pocket of money. For measuring angle of the deviation, as we can see, all of the study using prismatic alternating cover test or Kramsky, but this is not affecting the success rate for the final outcome. So I will give also 1 pocket of money for this point. For operation time, for BMR, it's surgery around, we will give time around 1 hour, but since we are comparing with procedure of 5 minutes, so I will keep it small pocket of money. So let's, I hope that's enough to convince you that the surgery have a good option for those patients. Thank you.
Thank you, Dr. Tagreed. We'll have the poll question now after the debate. Is conventional strabismus surgery highly successful in patients with cerebral palsy and Down syndrome? Yes or no? Let's see. Final call. Highly. 50-50. So we close at 50-50. 53, and we're still the same, not any difference from before. Yeah, quite a difference. Okay, we'll move to our next debate, which is Botox versus surgery for residual esotropia after strabismus surgery. It will be held by Dr. Mohammed Al-Shamrani for Botox. He's a consultant pediatric ophthalmology and clinical assistant professor, head ophthalmology unit, director of pediatric ophthalmology fellowship at King Saud University Medical City in Riyadh, versus the surgery with Dr. Sameh Sulaiman, professor of ophthalmology, Alexandria University of Egypt. Dr. Shamrani. Let's have the poll question first. What is your preferred option for managing a 10-year-old child with 20 prism diopter residual esotropia post-maximal BMR? Botox to both medial recti, lateral rectus recession, medial rectus re-recession, observation. Final call. Okay, so I think, okay. Okay.
لانه وقفت بس ترى.
Okay.
لو تكلمت ايش حيصير؟
Final call. 58% for lateral rectus resection, 42% for Botox. Close. يعني the race is very close. Let's have your argument, Dr. Shamrani.
I hope I can push it more. طيب السلام عليكم مساء الخير جميعا. Thank you, Dr. Shada, for organizing this very nice meeting and session. And I hope you can increase the rate of people who do Botox for these cases. طيب. Residual esotropia rate reached 20 to 40%, especially in the first short post-operative period. There are some risk factors that are known to be associated with undercorrection, which are younger age at surgery, large angle of deviation, if there is lateral rectus under action, higher hyperopic refractive error, and we have good number of patients who's having infantile esotropia and they develop accumulative esotropia with time. Some technical causes that may lead to undercorrection of in our surgery. If you have wrong measurement, either wrong assessment of the operative angle before surgery, if the hypertrophy is not corrected well, and there is some element hypertrophy is not corrected, this will be manifested after surgery. Or sometimes we have wrong measurement interrupt. This can be secondary to wrong caliber measurement, or something that we do sometimes when we do surgery. When you hold the insertion, you pull it forward, and if you take a measurement from this area, then you will be undercorrect by about 1 millimeter. So always when you do surgery, try not to put your caliber at the area where you are holding the muscle insertion. Our fear is consecutive exotropia.
which is a real. And we know that there are some patients who do spontaneous consecutive exotropia on their own without any intervention. And consecutive exotropia post-surgery reach up to 30% and even more. And the younger you follow the patient, the more cases that you will see. And I told my fellow all the time, when you start seeing your consecutive XT, this means you are getting more experience. There is one study that involved 85 patients and were followed for 40 years. So they called them and they record their alignment after 40 years. And we see that there's consecutive exotropia, it's increasing. So the increased number of surgery will increase the consecutive XT. They have 16 patients who have more than 2 surgeries. More than half of them develop consecutive exotropia. So the more surgery you do, the more consecutive exotropia that you may have. So forwarding. While if you do Botox, you have transient consecutive XT that you want to see. Usually it's often 2 to 3 months, but the long-term consecutive XT is rare. It's less than 1%. And it was found that the patients who develop consecutive XT, they are actually patients have only 1 Botox injection. This means maybe they have on their own build, they are prone to consecutive XT. So if you do surgery, they may bring them to consecutive XT more. So when I asked to prepare this review, I looked in the literature. I searched PubMed looking for combination of word esotropia, undercorrection, and Botox or botulinum, esotropia, residual, and botulinum. And I look in the literature review on Botox, recent ones, and I look to the study that they're referring to when they study when they look to the and mention Botox as indicated in case of residual esotropia. And they found only 2 clinical trials by one surgeon, Dr. Tejidur. And I will discuss them with you. There are some 2 other studies. One of them have only 5 patients, and they are referring to this study. And this patient, they have BMR resection and the BR resection. And another study included 20 patients. Only 5 of them, they were residual ET. The other, they have consecutive XT or consecutive ET. So there are not much in the literature for this study or for this group of patients. So in this study, they have 47 children with acquired esotropia who have residual ET after surgery. They develop esotropia at 20 years of age and later. They were randomized to reoperation, 24 patients. And even in this study, they have includes 4 patients consecutive exotropia. And botulinum toxin patient, 23 patients. One of them was consecutive XT. And the definition alignment was within 8 present diameter of orthotropia. At 1 year, the reoperation was 75% success rate, and the Botox was almost 70%, and it was not statistically significant. And at 2.5 years, still the reoperation is slightly more, but still the difference is not statistically significant. And they found that the early injection within 3 to 6 months after the surgery may give better outcome. So that one in acquired ET. This is the other study by the same surgeon. It's almost the same year. That one was 1998. This one 1999. And they looked to the infantile esotropia cases who had surgery and have residual deviation. And they were operated for first cerebral surgery by 24 months. So they have 55 patients. They divide them on randomized them to 2 groups, 28 patients, 4 of them consecutive XT, they have reoperation. And 27 patients, 2 of them consecutive XT, they have Botox injection. And you can see the result at 1 year, 75% of the reoperation, they get aligned, and about 63% the Botox group. The difference was not statistically significant. At 3 years, 67% and 59% in the Botox group. And so Botox achieved good outcome, and it was not statistically significant from the reoperation group. The fusion was achieved in both groups, and stereopsis was also comparable in both groups. And also they found that
Earlier injection within 3 to 6 months post-surgery give better outcome. So in conclusion, since mid-term follow-up, the botulinum toxin looks comparable to surgery for residual esotropia. And on long-term follow-up, we know that the risk of consecutive esotropia increasing to reach about 30% of cases, and this increased the number of the operations. And since we are small community ophthalmologists and people know us, I have one patient I operated on her at KKH for esotropia, BMR resection. Post-op, she has almost the same angle. Then I did for her BL resection. After that, she still has small ET residual. This was in 2013, 2014. Then I left KKH, I feel in peace, patients are there. I will not see them. She came to my private clinic 1 year back with consecutive XT. So the XT is happening about 30% of cases, while Botox has only 1% of cases have consecutive XT. So I think depending on this, Botox worth to be used as initial treatment for undercorrected esotropia after some surgery. Thank you.
Thank you, Dr. Shamrani. Dr. Sameh. Dr. Sameh Sulaiman.
كده شغال. السلام عليكم. I would like to thank the organizing committee and Dr. Shada for including me in this wonderful meeting. I would like also to thank my opponent, Dr. Shamrani, for a very nice presentation. He had facilitated the way a lot by discussing the botulinum part of the debate. So let's start by, I want to go back. What's residual esotropia? So this is residual esotropia. When you ask anyone, it is residual inward deviation following a previous intervention for esotropia. So as we saw all day long, the interventions are either Botox or surgery. So all cases of failed Botox that cause residual ET will not be treated by further Botox, will be treated by surgery, as we all discussed all day. So there is no debate that residual cases of esotropia after failed Botox will be treated by surgery. So we only speak about the cases of residual ET after failed previous surgery. I am an advocate of going for surgery because the literature is very limited in Botox and residual ET post-surgery. And as Dr. Shamrani said, there are only 2 papers more than 25 years ago, never replicated, that showed that they are comparable, even the results that the surgery are slightly better or the alignment is slightly better 3 years after the intervention. Surgery is better because we have variable options. We can do bilateral rectus resection, and this is the standard. You'll find lots and lots of publication emanating until this year saying that the success rate is in the range of 60 to 80%, going multiple and multiple publication and even go back into the previous century. You can do unilateral and bilateral rectus resection according to the dose or according to the deviation. So if there is this publication published in 2010 said that if you have less than 15 prism diopter or less than 20 prism diopter, you can go for a unilateral lateral rectus resection, and that the best angle is 15 prism diopter, where you can get the highest efficacy for unilateral cases. Also, you can do bilateral lateral rectus plication, and there are published literature regarding that, and they compared the lateral rectus resection to the lateral rectus plication in this publication, where 57 patients were included more than 25 prism diopters, and they did comparable numbers between both groups, and they found that the success rate is more than 70, and it's comparable in both groups. You can even, if you didn't have done the maximal medial rectus recession, you can re-recess the muscle. And there are also this publication, recent publication, had compared the lateral rectus resection versus the medial rectus re-recession. And again, it is comparable success rate in the realm of 67 to 54 percentage of success. This variability gives us the flexibility during surgery. So when you go for Botox, you'll only inject the medial rectus. But if you go and you were deciding to do one surgery and then intraoperatively, this is not working. Yeah, intraoperatively, you, oh, there's something wrong there. Sorry. Yeah. So intraoperatively, when you see the force reduction test, you expose the muscles, you see the muscle integrity. Sometimes you change your preoperative decision. So surgery gives you this option to change whatever you were deciding before going into the surgery. Plus, surgery can allow you to do adjustable. You can adjust. You can use adjustable sutures, and you can improve your outcome, especially in older patients. You can do your surgery and then put the patient on adjustable suture. And this is the report by the American Academy of Ophthalmology that, yes, there is no level 1 evidence for the effectiveness of adjustable suture, but many publications of level 2 and level 3 evidence tells us that adjustable suture gives us better motor alignment outcomes for this group of patients. All these factors leads to more controllability and predictability of the result that you are aiming for in this group of patients. And I will finish by this recent publication, 2016, and these are the highlighted conclusions. So in unilateral versus bilateral laterectus resection, less and more than 20 prism diopters in 80 patients. So the unilateral patient showed greater dose response. The success rate was in the about 84% of the patient. There is no variable that was found as a risk factor for failure of reoperations, and surgery is easy and very highly predictable in cases of residual esotropia. So I think all this makes the surgery the winner, and I hope that you consider it in these kind of patients.
Thank you. Thank you, Dr. Sameh. Let's have the poll question again. What's your preferred option for managing a 10-year-old child with 20 prism diopter residual esotropia post-maximal BMR? Botox, lateral rectus resection, medial rectus recession, or observation? Yes. Now we're almost the same as before the debate. Final call. 1, 1, 2, 2.5, 3. 50-50. 50-50. Both parties are happy. With this final debate, we come to our final debate session, and we'll do some discussion, a brief discussion, questions and answers. We'll take those from the online. Let's see. The question is Botox safe in patients with myasthenia gravis? Those who did Botox in neurological diseases can answer this question. Dr. Abdelal or...
I actually have no experience in injecting Botox for this patient, but I have not come across any paper, but I don't see why not. I think it can be an option. You just have to wait for the angles to stabilize, and why not give Botox? What do you think?
Me totally. Just the only thing I will not do it till the patient is stabilized by a neurologist. Yes.
Yeah, fair enough. Any questions from the audience? Dr. Kharashi?
One small comment I want to add to the patients with the partially accommodative esotropia. I think one aspect we have to look at is the quality of life for this group of patients, because they are all young kids, so they are 6 to 10 years of age, very critical age in their social aspect in school. And so if you do surgery that takes one day and then you can fix the problem, this will make it much easier for the patient and for the family in terms of social aspect, versus if you do Botox, knowing that it will take 2 or 3 injections, so that may take over a year period of time. Not to mention that initially after Botox injection, you are expecting to have a large angle of XT, and this really put a huge stress on the kid, especially in school, especially if it's associated with ptosis. Another thing is amblyopia at this age group. So correcting the alignment as quickly as possible obviously help improve the amblyopia. But if you're going to take a longer time to correct the angle, even if you can at the end reach the same result, then I think you're delaying the treatment for amblyopia if you go with the Botox route. And that's why I prefer surgery for those patients.
I totally agree. I did not mention that in my presentation, but I think surgery recovery is quite fast. It takes few days, while Botox might take longer for the consecutive XT to resolve and for the ptosis to recover as well. So I think this is a very important aspect. That's why I believe that for those group of patients, surgery is the answer.
So I have to defend Botox again. So one thing, what you mentioned, I totally agree on it. But once, as Dr. Misfer said, once you see a complication, then you would be really afraid. Like if this was my child, and I know there is a risk of endophthalmitis, risk of slippage, risk of other things, then I will say, well, I can use Botox. This is one thing. The other thing, if you have a high volume of patients who comes in your practice, and in one clinic, you will see like 6, 8 patients are fit for surgery, okay? Surgical candidate. Then if you can eliminate those numbers to be only 2 or 3 by using Botox, I think that will be a success. Like in one session, at least in KKish, sometimes we do 10, sometimes we do 12 patients. It's only in 4 hours. In 4 hours, you cannot do that amount of surgery for those patients. And do those patients will have success? They will. Like if you did 12 and 6 of them are cured, then I believe that is a really good option to be done in our practice.
Well, 6 of them, that's a cumulative success. And plus, if you count the number of days that this patient was in exotropia, the number of times that you had to bring him back for another injection, then that will contradict it. I don't think that specifically, I'm open for trying Botox. I'm not against Botox, but I think you have to be selective. And for this group of patients in particular, I think surgery is so much better.
And I agree with Dr. Ma'an for those patients because of bullying at school. And our population is dangerous in this. They may give the child one name that will hold for him for life. So for me, I have a patient who's in this age, 6, 8 years, and they have larger angle. I lean toward surgery more than going for Botox for this reason.
I'd like to thank Ma'an for his input regarding this type of patient, but this age of a group, I go discuss the situation with the child before I discuss it with the family. Some of them, they are ageotropic at the school with the glasses, and they still need further surgery. They are already strabismic, even if they are at school. If you do botulinum and they become XT, they are still strabismic. I do surgery when I find the child is fragile personality. Those kids with strong personality, I didn't care, even if they become XT. I show them the picture before I do the surgery. I go and browse in the mobile and I show them what will happen. Some of them, they said, no, I didn't want surgery, I want the injection. I go with the injection. They are insist for surgery, the family, but the child not with the surgery, I go with the child opinion, even if he is 6 or 8 years. Regarding, there's one point was mentioned by the success rate with partially accommodative esotropia. The success, I think, it will depend on how soon you caught the child. If you caught him early, let's say that he's become intermittent and glasses given, he came to you, he still has 30 prism diopter of esotropia. If you do botulinum on good timing, the success rate will be very high and there's no need to redo. Fusion, in my opinion, is a memory. If you take a child who is 1 year from his mom and you drop him with his aunt for 1 month, he will forget his mom after 1 month. He will not know that the other lady is his mom. But if you take a 5-year-old child and you keep him with his uncle for 1 month, he still memorizes his family, kids. Well, the season, if you caught the child early, you could restore, you could reset the fusion ability back. If you ignore him for a while, treating amblyopia, rechecking the glasses, bring him back for cyclorefraction, your surgical waiting list is high, the family is not motivated, you lost him, even if he has good fusion ability. At KKH, we are doing about total of maybe 100 cases per month, mixed between surgery and botulinum. For this reason, I think the timing for surgery is very important. I just have a few points I would like through the discussion, like to go through them. We do about 80, in the clinic, we have about 80% of pediatric ophthalmology are strabismus. I didn't know about your same, much less. At KKH, 80% of our patients are strabismus cases.
Yeah, in a pediatric
Yeah, because there's a general hospital.
It's a pediatric hospital. So in pediatric hospital, we have a lot of other
One point is mentioned about maximum and super maximum recession. We used to be, receiving such form of teaching. I will not resist any medial rectus muscle more than 5.5 to 6, by all means. If I decided to resist it more, I will put non-absorbable suture. Because with time, it will slippage. Regardless of your skills, you're a good surgeon, everything is went fine, but this muscle will move, it will not stay. We are doing also inferior oblique injection for botulinum. For this reason, Dr. Sisma would like to do a prospective study where we could do. I'm doing inferior oblique injection. For this reason, I could succeed. I could say that there is a 50% success. I didn't need to go and do myectomy or weakening. What is more? Shadashi show us one nice forceps to hold the muscle.
Mendoza forceps.
Yeah.
We
I didn't
recently
know how
ordered.
painful it is. Did you use it in the hospital?
We just got it. We just ordered and got it, but we do all of our Botoxes under general anesthesia.
Yeah, with this forceps or without?
Without this forceps. So we just got it. We did not try it yet. Yeah, you get the muscle. I heard from different users that you have to file the tips before using it to decrease in the sharp part of the forceps itself. So on the listserv, someone recommended that you file the tip of that forceps.
My concern with this forceps, if the patient is under mask anesthesia, it will be very painful. You have to give him some propofol or something.
I actually inject all my patients in the same technique without this forceps. So I use a 0.03 and I have no problems. Yeah, so the way I showed in the video, forceps, with a tooth
you
forceps.
Are holding the muscle with the forceps?
I hold the muscle with the forceps. I elevate the muscle, make sure that it's...
We are not doing that.
Yeah, I know. You inject with the bubble technique. No, with mask anesthesia. Yes, not LMA. Yeah, I have no problems.
Okay, we'll wait for your experience with this forceps and
Sure,
let's-
I'll let you know
I
next
think it's
meeting.
very painful.
We'll see if the patient feels any pain.
I would like first to thank all the panel to their contribution, their comments. My comment about the injection of Botox, I didn't prefer to inject inside the muscle except if I am doing intraoperative and a direct visualization, because at the end, I'm not sure I'm injecting inside the muscle or behind the muscle. And it happened with me sometimes. You see the effect is not desirable as you liked it to be. And the other issue, a lot of cases they develop huge subconjunctival hemorrhage and so I didn't like to inject inside the muscle or to hold the muscle. I usually inject near to the muscle, above it, and then I become sure that it will diffuse to the muscle.
Application or try to avoid the insertion of the muscle. Most of the big blood vessels at the insertion. So this usually if you start to moving the needle to the insertion, there is a high chance they will end it with hematoma.
Yeah.
But what we do it a little bit, maybe 3-4 millimeter behind the insertion.
Yeah, exactly. Until I see the ballooning of that subconjunctiva.
Okay, we have from the Zoom audience, we have a question. What is the outcome of Botox in nystagmus cases? Anybody would like to answer?
So we have a patient of nystagmus. So when we injected the Botox in the recti muscle, it did decrease the nystagmus, and the patient reported improvement of the quality of the vision.
Which muscles did you?
All recti.
All recti.
All recti, horizontal,
Vertical,
all horizontal recti, medial and lateral.
We do it as a diagnostic of the outcome of surgery. Prior to the surgery, we offer the patient for horizontal recti injection because we're going to recess the recti 8 to 10 millimeter. If they appreciate the outcome of the botulinum, we do surgery. If they didn't appreciate it, they didn't do surgery.
What's the aim of surgery in those patients?
My aim is to dampen the nystagmus and give the patient better quality of control of the nystagmus, especially with cases of albinism. Albinism, once you, Eugene Helveston, he doing this procedure even for non-albinic patient. But at that time, he do it just relaxing the recti. He think that by this way, the nystagmus amplitude become less, the patient could have better control and less dyslexia with difficulty when they are reading. For this reason, before I do surgery for such patient, I go and give injection to all the recti and bring the patient a few weeks later and ask him. If they report to me the quality of the vision is better, I do surgery.
And what do you do in surgery?
Medial recti and lateral recti incision. Okay. 8 to 10, 8 up to 12 millimeters.
I have not tried it in nystagmus in particular, but I've read in the literature that you can inject it intraconal, or you can give intraconal injection.
As a diagnostic, or
no, as a therapeutic for all 4 muscles. There are
I think
papers.
Dr. Awad is doing such thing, but he has to bring the patient so frequent.
In the literature, it was not convincing because they had a lot of vertical deviations. So that's a concern.
In this case, do you do equal units of Botox injection into each middle?
So 5
5
units
to each muscle?
For each per muscle.
5 units to each muscle.
Per muscle.
Total of.
This is a diagnostic prior to the surgery. If the patient appreciate that there is a better quality of reading, faster, he could control, even the vision sometimes improve.
Yeah, I tried it on one patient actually, and he reported better vision.
Shada, she's asking what is the alignment after. Depend if the patient has XT or ET, I consider ET and XT at the surgery. If they are straight, but they have nystagmus, I didn't consider the AT or XT. Just go with 10 millimeter recession for all.
10 millimeter for medial rectus?
Medial, lateral.
We have one more question from the Zoom audience. How would you go with Botox post-surgery with disturbed anatomy?
We measure from the limbus about 2 millimeter, where is the insertion, and then you inject there. Usually you go to the caruncle. So just go into the caruncle area and inject in that area.
There was one paper describing injection in reoperation after surgery, and they described that you have to have EMG guidance or a Mendoza forceps for that specific group entity to make sure that you're actually injecting in muscle. I have not tried it myself. I don't inject post-surgery, but that was mentioned.
There is an option. No, I agree with Safe regarding we insist a lot about the injecting the Botox into the muscle. No, we found similar results when you put the Botox around the muscle and you reduce a lot the risk of perforation, because perforation happens. No, we underestimate this when perforation happens. Yeah. And in these cases that the patient is already operated, you have fibrosis, the anatomy is already distorted. I think that the option that Safe says we go with this theory around the muscle, and works.
And usually have good outcome. We are seeing good pulsing.
Yeah, exactly.
In the caruncle.
Actually, talking about endophthalmitis, I have not seen endophthalmitis after strabismus surgery in my practice. I actually saw endophthalmitis in a post-Botox injection. The only reported case in the literature came from our hospital with endophthalmitis. It's published in the Journal of Strabismus and Pediatric Ophthalmology.
Was there injection of the muscle like to the globe itself? Or?
Yeah, it was penetrating the globe and it was injected into the globe. The only one in the literature.
Okay. So cases with endophthalmitis, but after strabismus surgery, but yeah, surgical. Yeah.
We'll take one
Even with
final
RD.
question. Thank you for that interesting talks, all of the speakers. Still, my question was not answered yet. If you give 3 times Botox injection for partially accommodative esotropia, and then you have a residual of, like, let's say 30 prism diopter esotropia.
Goes to surgery.
No. My question is, if you go to surgery, would you go for the same measurement of the angle, or you are going to decrease?
You go for same.
Because I think the muscle received 3 times Botox.
All the time. I mean, the muscle is recovering. I mean, if the patient has, why they deteriorate? Because the fusion is poor and they didn't recover, or maybe they have antibodies against the Botox where the response is poor.
Okay, great.
For this reason, I mean, consider the same surgery. The only thing that if you find that you need to do recession more than 5.5 to 6, I prefer to use non-absorbable to prevent consecutive XT few years later.
I have a question regarding cerebral palsy and Down syndrome. Do you follow normal surgical tables or do you decrease the surgical tables?
Under.
Under?
They had the spastic and flaccid. And
I actually, if anything, I would prefer doing over because the under corrections that I see, yeah. I mean, in my experience, I think we should do more than normal. Yeah, the muscles are weak and I didn't get consecutive. I always get under correction as if I didn't do anything. And I do the normal surgical tables. That's what I follow.
Ophthalmologist will see the consecutive, not us.
Probably. Probably. So I don't under correct in the surgical tables unless I have recessed the antagonist. So I go a little bit lower in my tables in that specific reason. For cerebral palsy and Down syndrome, I just follow normal surgical tables. Yeah.
Sorry, I just have one question. Did you notice that the refraction or psychological refraction is increasing after giving the Botox injection? Because sometimes the patient is having, let's say, 2 diopters of hyperopia with the partially accommodative esotropia, and after giving the Botox on follow-up, I used to repeat the cycle of psychological refraction if the patient didn't improve with just one single injection. And I noticed that the refraction is increasing. So if I increase the power, sometimes they will improve.
Increases hyperopia or increases myopia?
Hyperopia. So it will become, let's say, 2.75, sometimes 3.
In our paper, we compared refractive error before and after Botox and surgery. We actually noted decrease in the refractive error, but I think that's a normal aging thing.
Yes,
So I don't think it's because of the treatment. It's because of just a normal history of the disease. Yeah.
Because the normal growth and change in refraction from 0 to 7 years of age, that hyperopia stays the same or even increase.
Yes, increase. Yeah.
Regarding surgery and refraction, I'd just like to share with you my approach for patient. The patient needs surgery, strabismus surgery, and at the same time, he will need a refractive correction or surgery. I prefer to do the strabismus first, prior to any refractive surgery. Once you do medial recti recession or lateral rectus recession, this means that there's a high chance for such patient to has more myopic shift. And they saw cases where they started with minus 1.5. After medial recti recession, they become 3.5 and minus 4. For this reason, if you do a refractive surgery prior to the strabismus, it will not be good. That means patient will need maybe more refractive surgery. For this reason, I prefer, if you have a patient with refractive needs and strabismic needs, I prefer to do strabismus first. Once it is stabilized, he could go for refractive surgery. For pediatric, as mentioned by Man, for the first 6 to 7 years, sometimes some of these kids, their hyperopia become more, and after time, they will get less.
Okay, I think with this, we will conclude our very rich, heated pediatric ophthalmology session, Botox versus surgery. And I'm sure everyone now will think differently regarding Botox versus surgery in their practice. Thank you everyone for your attendance. Thank you for your patience because we exceeded the allocated time, but I think the discussion was all worth it. Thank you for all the speakers. Thank you, the Saudi Ophthalmological Society, and thank you, Dr. Shada, for organizing this very enriched talk. Thank you so much, and we'll see you for another